Good afternoon, everyone, and thank you for coming to this special workshop. We appreciate all of those who are streaming in and listening, and hope that, well, we don't hope, we know that we are going to get some very updated information that we need to hear, and even professionals from out of the school district have offered to come and give us some insights and some data. I did receive something from a former board member. Many of you remember Coach Clark, and he just today said, "Please know you all can only do what you can do. I am sure you know that better than anyone, but I have not heard of a school district that has solved this puzzle. From Fairfax County, Virginia to Los Angeles, California, school districts are groping in the dark looking for the right answer." And I think this is such a pioneer thing for all of us, and there's so many people out there that have so many thoughts about it that we do need data and we do need information, and for that reason we are having our board member to do our due diligence as a school board for this workshop. And it wouldn't be right if we didn't have our amazing superintendent, Mr. Pye, and he is with us tonight from his home, and we're going to turn the time over to him.
All right. Good afternoon. It's a pleasure to be able to address you, even though it's awkward. In 22 years, this is the first workshop that I've missed, and a rare experience to be talking to people by video, but we'll see. And I'm not real good at this, so I'll do the best I can. But the reason that I'm not there is I have tested positive for the virus, so I am quarantined. And so I'm one of those statistics now. When you look at the district data report and you see the number one of the district office staff, that is me, the superintendent. That's currently the one they're referring to, since we get about names. But I have no problem sharing that, because it makes what we're discussing tonight more real than ever. This is a deadly virus. It's not to be taken lightly. It's really a puzzle, but when you don't know what tomorrow holds, if you're going to wake up ill and you might not recover, you just don't know. It's so unknown. But so far, so good. I'm having every symptom known to man, but they're mild, and they're not staying consistent. As soon as one goes away, you would might appear. So I'm hopeful that within a few days, they'll all disappear, and I'll be back where I need to be with everybody else. But please know that I have been right at the forefront by phone and by video with my team in Dorchester, and we have looked at our graphs, talked about things, met with the principals, taken surveys with teachers, administrators, our team in each of the schools, our leadership team, to try to access what is going on. We're finding that it's just real hard to get a pinpoint answer where everybody appears to be, falling here. They're all over the place. And I'm so proud those people are sharing their perspectives, and they should share it. It doesn't mean we have to agree with you or whatever, but put it on the table and let us look and see if there's something out there we've overlooked, or maybe we need to communicate better as to why we're not able to do it. So after tonight's presentation, I think you board will be enlightened tremendously, as well as the public, about the various things we have put together for you. My team is top notch, and you'll see that tonight. I'm so proud of them. And so without any further ado, I'd like to turn it over to Mrs. Eastep and Ms. Radcliffe for the Thank you.
Thank you. Mrs. Eastep, let me just, for housekeeping purposes, could everybody turn their phones off at this time? And also, if we have questions, and I hope that we do, let's wait until Ms. Eastep is finished with different portions of it. And if anybody has questions, you let us know that it's time that we can ask those questions.
Yes, ma'am.
Thank you.
You're welcome. Good evening, Chairman Robinson, board members, and Mr. Pye. This evening, before I start, this is Lori Eastep. For those of us that you're listening through live streaming, I am the Executive Director of Elementary Schools. And as Ms. Robinson said, the purpose of tonight's presentation is to provide the additional information and data that was requested by the board at their last meeting on November 23rd. Currently, we have been analyzing additional data pieces to help us make the best decisions for our students and staff. These data pieces were not yet available when we first started talking with our reopening committee and having those meetings. So we're fortunate to have more data now to share with you. Our district team has prepared several slides to share with you this evening as you consider next steps. We will be reviewing the coronavirus data at the state, county, district, and school levels. We will also show survey results that Mr. Pye alluded to from teachers and our school leadership team, as well as district substitute information. And then finally, we will explain our 4-phase model for transitioning to full face-to-face and the process and logistics that are involved in moving forward. As a reminder, this evening's presentation focuses on those students who are currently in the school-based hybrid model, not the virtual academy. And as Ms. Robinson alluded to, I had this in the presentation already, we'd like to ask that you jot down any questions that you might have and hold them until the end of the presentation as we go through. Since we do have several slides, some of your questions may be answered not at the point that you have them, but later on. So if you would do that for us, we would appreciate it. And at this time, I'm going to turn it over to Mr. Schmink.
So good evening. Again, for those who are watching, my name is Thad Schmink, and I work in the Office of Assessment and Accountability, and my job is mainly working with data. So they have asked me here tonight to present some data related to the state and local COVID-19 numbers. So as you can see here, I'm not going to go over too in-depth actual South Carolina numbers. I'm sure that you have all been watching DHEC charts. I'm sure that you've all been getting Ms. Conaran's updates. But we do want to just kind of show some trends that, as you know, obviously in South Carolina there has been an uptick, and we want to also demonstrate that pretty much what's happening across the state is what's happening here in Dorchester County. Of course, we would like it to be that if the state were going up, that our county would somehow be doing something where we would look far better than the state, but unfortunately, we pretty much mirror the state. Now, being the data guy, I also want to make sure we point out that that blue line is the number of new cases. And while, please remember the scale of this graph, and that when that blue line moves even just a few millimeters away from the bottom line, that is still a pretty significant shift for that particular line. So just kind of want to draw your attention to that. The timeline kind of helped to put the data in perspective. You know, up until June, everything in South Carolina was relatively small. Then from June till September, we saw a major uptick, if you were to graph this out by slope. And then that's why you see that blue line creep away from that baseline where we would like to have it. And then again in September through late October, early November, and you're going to hear me say this often tonight, this is where we saw sort of a steadying, a flattening of the curve, if you will. But unfortunately, as you can see here in November, and with the latest data that we have from December, that little blue line is starting to work its way away from the baseline once again, somewhat indicating that we're headed for another upward tick. On this next slide, we'd like to just talk a little bit again about that timeline. Back in the summer, when all the initial decisions were being made, as you know, we were, for our incident rate as well as for the percent positive rate, we were considered to be in the high category. And again, as you can see there in September all the way through most of November there, of course November sort of picking up some steam right around Thanksgiving. That's what I'm talking about with that little bit of that, I don't want to go so far as to call it a lull, but at least a slowdown. As you can see on the 12-3, we started to pick up. And unfortunately, we didn't have the numbers from DHEC prior to printing this packet for today, but we were able to get them recently. And today's number, so these are in about a week increments here, but just today's number over just 3 days ago, we've already jumped an incident rate up to 382.7. And our percent positive is 16.3. And I know there's some confusion about percent positive, and there's advantages and disadvantages taking a look at things percent-wise, but the more you test really has no effect on percent. So whether we're testing more or not testing more, that's the joy of percent, is that it keeps everything relative. So just to dispel any ideas there of we're testing more or testing less. Also keep in mind that when DHEC puts these numbers on here, these are through the swab and through another thing. This is not the what do they call it, the rapid, thank you, the rapid test. And so, just wanted to say that, we're now started to we're reapproaching those same numbers that we saw back in August. And I think that's important for our timeline. The other thing I want to point out as I go along tonight is not just some of the data, but try to help you. Not everybody gets the joy of working with data every day. So I hope that I will maybe shed some nuggets on how to look at the data as well. And one thing I try to assure people or to inform people is that how DHEC, the scale that they have, and sometimes you'll hear parents, I'm sure you're getting emails, referencing CDC scales. Just keep in mind that the CDC scale and the DHEC scale are not the same. Okay, so for example, when I looked at the CDC, they consider the 200 to be high, where DHEC has thrown in this extra layer of moderately high. On this next slide, we'd like to just talk a little bit about moving from the Dorchester County data into more of the zip code. People were very interested in knowing, well, Dorchester County spans a very large geographical area, so what does it look like? What's transpiring in our actual zip codes? And again, a little bit of the worry about this is that our zip codes don't overlay exactly with our attendance areas, but for the most part, the 483, the 485, and the 420 are predominantly Dorchester 2 attendance zone zip codes. So those are the ones that I would say that you would weigh more than the others, besides the fact that the other 3 zip codes represent a much smaller number, a much smaller population. The other thing I'd like to point out on this slide too, kind of with that data discussion, is DHEC often reports things in different ways. And one of the things that when you go on their website, they reference is reported cases, when these are the actual cases that are sent in by the doctor's cares and actual doctor's offices, hospitals being reported to DHEC. The estimated cases are cases that statisticians far beyond my skills use various formulas and various banks of data to come up with a multiplier. And what they've come up with, you'll notice, is a multiplier of 6.14. So basically what they're saying is that for every confirmed reported case, their data suggests that there are additional 6 cases out there that are not officially accounted for. And so as we talk about the data, and as you talk with constituents and just as you reference the data in the future, it can get a little daunting sometimes on the different websites, but just, the idea is to keep that in mind, that those are 3 different points of data that each tell their own story. And the last thing I'd like to point on this slide is just that, again, those three zip codes that are in our area, the blue represents kind of where we were when I took the data from August 14th. That's right about when we were starting leap weeks. And I just wanted to say, well, what happened prior, it matters, but for the sake of the school timeline, what's transpired. So the difference between the orange bars and the blue bars would be what's occurred since that date of August 14th. And I also like to point out one last thing is that total increase, that's all the way off to the far right, that you can see, again, those percentages that kind of equalizes each zip code so that it's a better way of, kind of comparing from zip code to zip code what's transpiring there. And again, those top 3 ones are going to give you far more of an indication because they're a much larger population. The percentages are going to be swayed as quickly by a few numbers. That's why you'll see a little more drastic changes in the lower 3 zip codes there. This slide just again talks about reported cases. These are the ones that are actually phoned into DHEC or sent into DHEC. And you can see here for all of our zip codes, we don't have one particular area that's doing a better job of not spreading it than another. Basically, all of our zip codes are all gaining right about at the same rate. And one more little tidbit I want to throw in there too about DHEC data in case you do decide to go back and double check my work tonight, and that is that DHEC is constantly updating even their historical data. Apparently, some doctors' offices are understaffed or are rural, and they're not sending in their numbers every week. They're batching them and sending them in, 3 weeks, or so the data is forever. It's a moving target, but it doesn't move necessarily that much. But just in case my numbers are a little bit off of what you see with DHEC. On the next slide here, we see the total number of new cases by zip code. And this is just kind of giving you an idea of, I like to look at numbers. Percentages are great, but I like to put a number to what is actually happening. So when somebody says to me, oh, we increased 6%, well, that's great. What is 6%? Is it 2, or is it 200, or is it 2,000? So for me, we can see here these numbers that basically when you add up all of our zip codes, which is going to be our most accurate for our attendance area, we can see that the number of new cases is definitely, since around Thanksgiving, been increasing. And the other thing I'd like to point out is that the number of new cases, if I could go back one slide real quick, and that is that, I apologize. I'll discuss that in an upcoming slide here in a moment. But as far as the new cases are concerned, again, following that timeline, I want to keep reiterating, the new cases, our first big event was sort of winding down around 9/11, 9/18, but we can definitely see the beginning of a new wave or a curve coming now. And then the next page is for those of you who like percentages, who just think better that way. There they are. You can see the percents. So you can see across all the zip codes, pretty much our instances of new cases are definitely increasing. We can see in 418, again, we see a doubling, but I'm not here to try to exaggerate anything. I want to warn you that you see a doubling, but that's one of our smaller numbers, so it's more susceptible to larger swings. But what is alarming that is one of our largest zip codes, the 483, has more than doubled in its rate of instance. On this next slide, we're just going to give you we've taken a look at the state, we've taken a look at the county and their zip codes, so what's actually transpiring in our schools. And the good news is that I think what we're going to see here is that the measures that we have put in place in our district, they are working. And these numbers are relatively low, which is wonderful. That's what we want. And I'm going to speak again to the timeline here in a minute, but what I want to point out is that prior to, if you look at that November 9 number, that means that this is all year-to-date data. So for the 10 weeks that we were in school prior or leading up to November 9, we only had 42 members of our staff test positive. So that's 42 members over 10 weeks. But when you look from November 9th to December 7th, that's a 58. So we've more than doubled in just 4 weeks. So our measures are working, and I think you'll see here in a moment, they're working across the board. But we are definitely still, with all of our efforts, susceptible to the patterns that we're seeing in the state. On the next page here, again, I think this shows how well all of our efforts are being implemented, all of our protocols, all of our practices across all of our schools. As you can see here, the numbers for staff who are positive are pretty well spread out amongst all grade levels, elementary, middle, and high. There's no particular hot spots, if you will, which I think, again, goes a lot of gratitude to the principals, administrators, and teachers who are making everything happen in our buildings for our kids and keeping these numbers as low as they are. And I think that, again, if you look to the little tables off to the side, the bar graphs, it's nice when you see the bar graph nice and flat. That means that nothing is really changing there over time. But you can see that those numbers, again, are all on the 12/7 date. They're all starting to creep up. So, again, those practices have been working. We're just against, well, we're up against COVID-19. The next page, again, I think speaks to all the efforts that are being made to maintain distance, to everything that our cafeteria workers and our bus drivers are doing to maintain that distance, and everybody wearing their PPE. And you can see again that none of our schools, none of our grade levels and none of our schools are a particular hotspot, which means that all of these precautions are being universally implemented across the district, which is, I think, really positive news to share. On the next slide, I know that people are very interested to know, okay, so as with Mr. Pai being quarantined this night, so how many people are like him, and how many people are finding themselves at home due to COVID? So here are some year-to-date numbers, and you can see that year-to-date we've had 264 of our staff members who've needed to be quarantined. And keep in mind that the average length of a quarantine is 10 to 14 days. And I think that that number is going to be important as you hear later on from personnel discuss some of the issues related to finances and substitute teachers. And then the number of quarantined students, and this was as of today, were 899. Now that's year to date. And I think important there as the data guy to point out, the instructional cost of having that many people out. I haven't quite put a number on it, but I would imagine that it's substantial. And then on the next slide here, we can see the number who are, so you probably want to know, okay, today, who is actually quarantined? What does that look like? We currently have 75 staff members who are quarantined, and we have 363 students. And again, I think you'll see from the numbers, it's well distributed amongst all of the schools. There isn't really a particular, some of the high schools will seem to have higher numbers, but of course, they have higher number populations if you're looking at things relatively. In my last two slides, I'm going to kind of bring this all back and take the lens and zoom back out a little bit and just take it 2 more points of data that I think are very relevant that I received from DHEC. And this first one here speaks to the age range and age groups that are related to people in our state who are coming down with COVID. We often hear that it does not affect the young. This data shows otherwise. It shows that, of the people who've come down with COVID, 4.3% of them have been under the age of 10. And if you look at our middle and high school age group of 11 to 20, they're at 13.8% of the total population who've been affected by COVID. Now, the other important part of data here is that, again, I think people have a misconception that COVID is really only affecting the elderly, and we will talk about that in a moment. And they are correct in that statement of the effect. But you have to also look at the age group between 20 and 60 to see that that's the group that is contracting it the most. So they make up the largest part, and that is, unfortunately, the same age groups of the majority of our faculty and staff. Which leads to the next slide, which I think, and I hope I phrase everything correctly tonight because it is such a morbid topic of death. And yes, the general public with some of the, the thoughts that are out there, we talked about the effect that COVID is having. Yes, according to the stats, there's a very low rate of death if you are basically under the age of 20, which is great news for our students. However, it takes a lot more than just students to run a school, as you're very well aware of. And for our younger faculty, the age of 20 to 40, the rate does definitely seem, I don't even want to put an adjective to it. I don't know if I don't even think reasonable when it comes to death is a reasonable adjective. However, I am approaching, myself, that wonderful number of 50. And I'm not so sure that I like those odds that I see up there. And I cannot imagine what it would be like for my colleagues who are nearing retirement, and they are now facing a much higher rate. And so that's just something to be, I want to point these data points out to you because, again, I think keeping those percentages in mind will help you when you're interpreting some of the data that's going to be presented here later this evening. And I guess my last thought on all this is something that I heard on the way over here today is just some reports, and I know that we have someone from the medical field who'll be joining us today, and perhaps our guests can touch more on that about the other long-term effects. While the death may not be a statistically significant enough to plot on a chart, we do have to wonder as well what other underlying conditions and other long-term effects may be resulting. And unfortunately, I don't have any data to share with you, as the medical community itself has not really published a whole lot on that just yet. But that is definitely a concern that I know that everybody's on their mind. And my only data I have to share with you is to say that I don't have any data on that at this point.
Ken, this is a good time that if anybody has a question, they can ask you. I do have one, if I can. How many, because you're a numbers person, how many students at the same given time last year before this was what it is, a pandemic, how many students were out comparatively on this period of time, this day or week, as compared to this year? Do you have that number?
So are you speaking to, so the data that I've shared with you today, I believe, only encompasses students who are been out or quarantined specifically due to COVID. Now we would have our other reasons for students being absent on top of that. So if you're asking me to compare, I can't really, there is no COVID data to compare to for last year. Trying to compare last year's attendance to this year's attendance.
With other illnesses like
With other
flu and
illnesses.
things like that, how many students were out about this time last year without the COVID versus this year with the COVID? I was just trying to get a comparison.
As much as I would love to give you an answer to that, as a data person, I'm always very hesitant to put wrong data out there.
Sure.
So it's something I will gladly take back to the office and research, and I can provide you with that. I mean, that's a very valid question about rates of attendance. And unfortunately, not being in the building anymore, my finger is not on that pulse as much as it used to be. We also have to take other factors into consideration as well, that around the holidays, there are a lot of reasons why students could potentially be out. And remembering back to my days of being a principal, the holidays always, without COVID, brought on a lot of extra absences. There's a lot of family stress, a lot of mental health comes out. And so I will also have to try to make sure I frame that data as comparable as I can.
That would be helpful. And my last question is, you had said that some are quarantined for 10 and others for 14.
Right, so the guidelines currently are 14.
Okay.
I've seen actually, as of today, some recent discussion, I don't remember if it was CDC or if it was DHEC, where they're saying with testing that quarantine could be lessened to 10.
Okay.
But I don't know what perhaps our district head of nursing could.
Okay, but before you leave, does anyone have any more questions, Ms. Cross?
In that data, when you're doing it, is there any way that you can check with CDC or whoever? And, because we have so many flu cases, just regular flu cases, and we have a lot of people absent, a lot of people die from just the regular flu. So in that number, could we tell which ones were flu?
So in the number that I'm reporting to you, that is only COVID.
No, I'm talking about in the ones that you're going to look up for her.
Oh, sure, yeah, so that,
Can
what I
you
will
find out
look
if it
up
was,
for you
if it
is,
was flu, if they were out because of flu?
sure,
regular
absolutely,
flu?
I can definitely take a look at our flu numbers, and I can definitely take a look at just overall absentee rates.
Thank
Sure.
you.
Thank you.
So of the cases that we have for positive students and staff, do we know if any of those were transmitted in the school? Is there any evidence of that?
Let me introduce Ms. Santa Monica.
Hello. It's impossible to know where someone contracts COVID. Even if you seemingly think that there's a link between two cases, there's no way to prove that you got it from somewhere or someplace. So we don't know for certain where any of those cases were from. And just to kind of go back to the two other questions, we do track student illnesses for flu when we reach a certain threshold. That information is reportable to DHEC. At this point, we have not reached any threshold of flu cases where we are reporting to the health department. As far as tracking historical absences, whether they be for illness, vacation, things like that, we could certainly compare that data, but it would be very hard to kind of compare the two because COVID is reportable to the health department. Flu only becomes reportable when you have an outbreak in your building. And so students can be out for the flu and it's not reportable to anyone. And then just to kind of clarify, quarantine is different from isolation. Quarantine is for individuals who are a contact of someone who's positive. That period at this point is 14 days. Isolation is 10 days, and those are reflected in the positive cases of students and staff. So those are two separate data points. If an individual is listed as being under quarantine, they are not under isolation. They're not counted twice.
Thank you.
Wait, can I go back to my question? But I understand what you're saying, you can't know for sure, but are there situations that have occurred that might make you think, if you have a cluster happening in one spot, in one class, are we seeing things like that?
We are seeing situations where we can kind of see a link between different cases, whether they be student or staff. DHEC also kind of tracks those things with us. They consider a cluster to be 3 or more cases in a 24-hour period in a particular building or location. We have had some of those situations where the 3 cases were completely seemingly not connected. Students were not engaging with one another, staff were not engaging with one another. We have had situations where we feel there could be a link, but again, there's no way to prove where someone.
And going a little further, what about taking in extracurricular activities, like sports and things like that in these kind of numbers in that transmission?
Sure, so they are all tracked in there as well.
It's grouped though, is there any separation at all? So do we know at all if that could be causing some of the cases that we're seeing?
So I will say we have not had a situation where we feel that there have been a mass number of cases that are tracked back to a particular extracurricular activity or sport. We always keep our eye on those things as they are obviously more close physical contact. It's not broken down in that data just to protect the confidentiality of the individuals who are positive, but we do internally, I do track that information to make sure that if we have a case on a team or in a particular cohort, we're ensuring we don't accrue more cases in that group.
I'm just wondering if we can make sure if we watch, if there are things that we're doing that could be causing transmission, we're aware of it. Did you see where I'm going with that? Right, yes.
And that's why we watch it so closely to ensure that in these situations where we know it's a higher risk activity, if there's an issue, we find out about it right away so that we can figure out what steps need to be taken, if that means a quarantine of the entire group, if that means shutting down the activity for a set period of time.
Exactly. That's what I was thinking.
We track that very closely.
Okay, thank you.
I've had a couple of emails about the wrestling that has just started, because that's certainly close contact. Is there a way to, are we going, there's no other way to wrestle but up close. So, do we anticipate probably seeing a problem there?
We always are looking out to ensure that we don't have any problem situations. We know obviously that's a close contact sport. We have safety measures in place. All of our athletes and extracurricular activities have a screening process that's done before they can practice or compete for that day. We take that very seriously, ensuring that our students and staff are all screened. They try to social distance the best that they can when they're not physically participating, like on the mat in wrestling. And we just, again, monitor the situations as they come to ensure that we don't have an issue in one particular area.
Does anybody else have, Evan, Mr. Guthrie?
I guess, are the quarantine students being tested, or is there any data as far as before they go back into school, or is that through the school, or is it on their own personally, or does that work?
Sure. So anytime someone is quarantined, it involves a phone call from me letting them know that they need to be out and for however long. Sometimes it's because those situations are school-based. The close contact occurred in school or at an extracurricular. Sometimes it's the parent contacting us to let them know their child's had an exposure and that they need to quarantine, and same thing with staff. During that phone call, I provide the same exact guidance that the health department does, and that's that they recommend close contacts be tested as soon as they develop symptoms. If they do not develop symptoms, they recommend testing in 5 to 7 days. We cannot, and neither can the health department, require that anyone who's under quarantine be tested. We do strongly encourage it, and if they do get tested, we require a copy of their negative results before they return. But I have some internal data for those that have been reported to me that they did get tested during quarantine, but we don't, again, we can't enforce it, so it's just a strong suggestion. Sure.
Any other questions?
I have one more, sorry. So just thinking about, this is definitely great data for new cases and increase in percent positive. Does any of this take into account the fact that more people might be testing right now? So obviously you're going to have an increase in your percent positive, an increase in your number of cases if more people are testing than they were previously. So I was just wondering if any of this data, I didn't think so, but I just wanted to make sure before, I'm not sure, just trying to clarify there.
Statistically, from a data standpoint, having a larger pool of people who are tested would not, obviously would change your number, but it would not change your percentage. And I think that's why we try to look both at percentage, which you saw in doubling, and we also try to look at number. And we look at number just to know, again, are we all sitting around here this evening talking about 3 people, or are we talking about 30, 300? What's the number of that percentage? So again, the number tested really only helps to strengthen the reliability of the data that we're getting, that it's not as whimsical if 2 or 3 more positive cases happen to be the next 2 that came in. Obviously, the larger your base number is, the more reliable and valid your number is.
No, that makes sense, yes, I see what you're saying. Mm-hmm.
And just one quick closing comment on the attendance, and that is that we also have to keep in mind, well, there's 2 closing points. First is also keep in mind that the data that you're seeing is actual from our district, and if we apply the same rule that DHEC is applying, we have to wonder that there's 6.14 other cases walking around our schools potentially that we're unaware of, that whether they're asymptomatic or not, they are still potential spreaders. And we also have to wonder about the attendance, is that it'll be very difficult for us to be able to disaggregate the reason behind why a parent kept their child out. I know that being in a lot of the district meetings as of late, a lot of principals have expressed concern about many parents just opting to voluntarily keep their kids at home, which is causing a little bit of an attendance issue because they are lawfully, or unlawfully keeping students at home out of fear of what is to come. And it's definitely caused for a lot of discussion and a lot of policies and practices that we have to put in place. But please do keep in mind that we're not just losing instructional time of students who are actually being quarantined, but we're also losing that contact with students who are being pulled and kept home. And we have seen an uptick of that. I don't have the exact numbers, but there has been an uptick of that.
Thank you. That's a lot of really good information. I did just think of something, and I don't necessarily like making comparisons, especially us versus, say, another district or even school versus another school. But I'm wondering if there isn't benefit if we could either pick out some other districts or school sites that have similar characteristics, same number of students, similar number of staff members, where they are maybe in a different model than we are in, i.e. maybe someone who is in more of a face-to-face model or something like that, and then overlay, and again, I don't know if that's even possible, because if they don't have that data, I don't know.
Very multivariable,
Right.
depending on rural, urban, socioeconomic status. Yes, I mean, we could potentially find a few other districts that would match in those areas and try to make some, but I'd have to take a look at that and before I could speak to how valid those comparisons would be, because again, it is just simply so multivariable.
Sure. Yeah, and I'm not looking to put a square peg in a circular hole, but again, if there's just any data for us.
Yeah, absolutely. I mean, we can say that the surrounding counties are exhibiting when we look at the DHEC. Now, the good news is that our rate of incidence in Berkeley County and in Dorchester County is pretty low compared to the state. Charleston has been a little bit on the higher side. I don't know the comparisons to our counties as of those last numbers that I gave you, but I do know that there are, as of today's data, there were 46 counties that were all in the high category. But definitely in the interest of time, because there's a lot before you, I will gladly email me your questions, concerns, and I will definitely try to provide that information back to you as quick as I can. All right, thank you.
Anybody else? Thank you so much for that information.
Thank you.
Good evening. I'm Elena Finari, Executive Director of Personnel. It's good to be here tonight. Mr. Schmink, thank you so much. That was a lot of data. I'm going to give you a little bit more data, not quite as in-depth as our data man back there. But as I begin to share the teacher survey data, I want to remind everyone that a return to e-learning was not an option we were discussing at the last board meeting on November 23rd. And at the time that the survey was distributed. So there was no questions about that, okay? Additionally, this survey was given to teachers as requested. It is imperative that we keep in mind it takes all faculty and staff, both certified and classified, to effectively run our school system. So this was just a teacher survey as requested, okay? The survey was open from December 2nd through December 6th, and I want to commend our principals and our teachers, because the principals did a great job of getting it out, and we had a great response. Our teachers responded, which was wonderful, because sometimes with surveys, you don't get a high percentage of responses. We did really, really well with our responses. The first question was just simply, tell us where you work, okay? And we hope everyone could easily do that. So there's your, you have it in front of you, so I'm not going to read through everything, okay? What's that? I'm going to come help you real quick. Okay. All right. The next question is just select the grade band in which you work, elementary, middle, or high. So you see those responses there. The next question was, which grade do you currently teach? And we did not have this question available for if someone picked high school, and the reason for that is because it is not typical for a high school teacher just to teach one grade. They teach courses and they span across grade levels. So that information was not needed at that time for the to complete the survey. The next question, and this was loaded, we were asking them, they had choices. Describe what type of classes or schedule you are currently teaching in. And is it face-to-face? Is it virtual? Is it a combination of both? So you can read those and see the responses there, and they range. There's a wide range there. The next question, because this was what we were talking about at the time. Seems like not too long ago, it was right before Thanksgiving, but the question was, do you believe that Dorchester School District 2 should return to a full 5-day face-to-face instructional model as early as January 4th for elementary schools, regardless of county disease activity, as long as individual school numbers remain low? We felt that was important to put that question in. We're not just looking at one piece of data, we're looking at multiple pieces of data. And 1,242 said no, and 357 said yes. The next question was same question to middle and high school only, and same response. They felt no, they should not go back February 2nd. That was the date we were targeting at that time for second semester for secondary schools. And again, you see the numbers there. The next question, and this is the one, I'm going to be honest with you, that the heart rates and personnel went up pretty high when we saw this result, because we just asked the question, if we go back face-to-face, 5 days, regardless of county disease activity, as long as individual school numbers are low, is it your intent to remain employed in Dorchester District 2? 1,210 said yes, thank goodness. 389 said no. Now, we all know with a survey, because this was anonymous as requested, people can put no and we don't actually know what will happen if that decision is made. But from a personnel person, my team, our whole team, we looked at this and said, oh mercy, because that would be a lot of spots to fill and we would have some vacancies in our schools. But again, we had to ask the question. The next question, because you got this question, if you said yes, you intended to stay employed, regardless of the county disease activity, as long as the individual school numbers remain low, how would you prefer to teach? And most would prefer to teach full day, face-to-face. And I think we can all say this. We all want to get back to normal school. I mean, that is our goal in the end. I mean, we would love this to all be over and so people can do their jobs the way we've always been trained to do. But let me tell you something. Our teachers, our staff, our principals, they are doing their jobs and other jobs to run the schools right now, to keep it going. And I just can't say that enough. The next question, again, we always do intent forms, and those are actually coming out officially in January when we return from the winter holidays, but we figured we'd throw this question in there too. Looking forward, is it your intent to remain employed with Dorchester District 2 for the 21-22 school year? Because believe it or not, we are already planning for next year. You guys know we have had a recruitment event, a virtual recruitment event in December. 1,026 said yes, 65 said no. I'm gonna tell you, that undecided number is the one, again, that caused us in personnel to have a little angst. Again, we don't know what the difference will be when they officially do them and they have their names on them in January, but we average, and again, this is just an average, and I am not Thad Schmink with all the data, but we average about 200 new certified employees each year, give or take, depending on whether it was a Terry year when that ended a couple years ago, or what have you. But if we had to replace 456 teachers, I think we all know they're not out there. So that would be tough for our district. So hopefully by the time the new year rolls around and those decisions have to be made and contracts have to be signed, we'll all be in a better place. The next question, again, this was just because you intend to come back to Dorchester District 2 for next year. We asked what type of class would you prefer? And again, we see many more would prefer the full day, 5 face-to-face, the normal school. Glad to see there's still some people who want to teach virtual, because I feel like that will always be around in 4 years, 5 years down the road. It probably won't be as large as it is now, and it may be a little bit of a different setup, but it'll still be here. We've proven we can do it. Some kids really do well in that model, so. And then again, a combination, because we always need flexibility in education, that's for sure. The next thing I just want to share is just some information about substitutes. And the reason we feel it's important that you know that is because we're struggling in the substitute area. A lot of our substitutes are in the upper age brackets that Mr. Schmink shared, and they are truly just choosing not to work right now. And I'm glad that they can make that choice, that they don't have to be here if they don't want to. But we have a total of 565 subs in our pool. Of those, 392 have not worked from August to December. That's a lot not working. So that means only 173 of our subs have actually worked during this school year, about 30%. Our schools, our teachers, they're doing a great job of covering when there are absences, because as you saw and you see from the dashboard, the quarantines, there are people out. And it's not like the job just can't get done that day. We can't have students in a classroom without a person in there. There's got to be a body in there to monitor and to teach, hopefully. So just wanted to let you know that. Sorry. Just giving you some quick numbers from October and November. Those fill rates are about 74% and 76%. We strive for about 90%. Mr. Matthews is back there, and when we see 90%, those are good days. We have not seen 90% this year, and I know our principals over there can attest to that. But we're about at 70. We're in the 70s to 80s, depending on the day. But that's just, that's where we are right now. Again, just showing you our average daily fill rates, some dates in October. For every 100 vacancy sub need, data says that we should have 300 subs available. And I already told you that we only have like 173 actually working, so we know that's a struggle to fill those spots. The last thing I want to share too is it's not like we're not trying to get them. From September to December of 2019, we had 133 substitutes trained. From September to December of this year, we've only had 33. We've had workshops, but they don't come, and they don't come to the workshops. The numbers are in single digits. We're still offering them, but we're trying to get more to come. But that's kind of where we are on the personnel side. So I'm going to pause for a moment, and then I'll turn it over to Ms. Radcliffe.
Does anyone have any questions for Ms. Radcliffe?
Ms.
I'm sorry,
Fenari.
for Ms. Fenari?
I just have a quick question. Looking at the early survey questions in there,
Sure.
and I don't know if this is for you or it might be for Ms. Santa Maria. School numbers remain low. Do we have a metric, or what do we consider low in an individual school?
We're looking at all the data on our dashboard. If there is not a high number of people who are infected or quarantined, those numbers we would consider them low.
Is that, so are we saying a percentage of the population, so like a percentage of the staff or students? I'm just trying to get, is there a certain number or percentage per school site that we would consider low, I guess, as a district?
Ms. Santa Maria might want to talk about, because you used the word cluster earlier, and there is that's an official term, thank you, but I'll let you answer that. I don't want to try to.
So as we had kind of touched on before, we work to kind of identify not so much just total number of situations, but whether or not they're in a certain period of time, whether they're in a certain cohort. So DHEC, again, defines that cluster as being a certain number of cases in a certain period of time or a certain number of cases in a cohort. What we're really looking for is those targeted situations where we can't, again, prove that one situation caused another, but that they're with the same group of students or same group of staff members or a combination of both. We have not yet gotten to a point on this current dashboard where we've had a particular school where we've had a concern that we've had to shut the whole school down. There have been some situations since August and since staff came back and students where an entire cohort of students did need to quarantine. Again, not positive cases, but exposure to a positive case or multiple positive cases. So we've been able to kind of isolate it to not having to shut an entire school down, but just maybe a classroom or a team or a particular department. We have had a handful of those situations, and we monitor those very closely for any further impact, but so far we've not gotten to a point where we feel like our spread is so high in a school that it would shut the whole school down.
Gotcha. Thank you.
Ms. Fenari, I did want to ask you, with the substitutes pool being so low, have you seen problems with having the classes have instruction so far this year?
Well, and I think that's where we've been lucky, because our schools are doing a great job of pulling people. Teachers are covering during planning periods. They're really working together to get that done. And, as far as speaking to specific instruction, I could leave that to my partners over there, but we haven't heard large complaints.
Okay.
And again, it goes back to, if I were out tomorrow, if I had to take the day off, there's not a group of kids looking at me to teach them that day. So I could be off, but a teacher, you have to have someone to monitor the kids. And they're pulling people, media specialists are being pulled, fine arts, guidance, school counselors sometimes, because again, we can't leave the kids unattended. But we have plans, we have people bringing their class, if it's virtual, inviting the virtual class into another class. I think we're doing a good job covering.
Okay.
I really do. But it's because of our principals and the teachers willing to help.
Just to follow up with that, have we thought about any kind of incentive program to try to get more subs in?
That's a great question. We have incentives for them working, so many Fridays or Mondays in a row. We offer them some extra money. Again, we've reached out to our sub pool, and they're just saying, I'm not coming in right now. But the ones who are here, if they're wanting to work and they cover other classes, we're paying them too. But we do have a couple incentives in. like I said, if you work, Fridays and Mondays used to be the big days for subs, so we kind of have, and if they work a certain number straight days, we give them a little incentive too.
Do you think there might be more options, more things we could do to entice them to want to work, especially since I keep hearing discipline problems are down? I mean, there are good things going on from what I'm hearing, and that's great. And so obviously I'm sure fear is a factor for
Yes,
many
ma'am.
people, and you can't overcome that. But if we, maybe could, I don't know, just a
That's a
thought of,
great
obviously this is something that,
Yes, ma'am. With incentives, there's a price tag, and I can feel Tina
Sure.
back there, her eyes just in the back of my head. And again, we're open to looking at more things, and again, we're moving along as best we can, but again, we're open to looking at other options for our people, sure.
And then one other thought that with a lot of times I know parents are our subs. So with kids not being in school all day or every day, do we think that is also adding to this problem of lack of subs, possibly? So in other words, if we were to go back full-time face-to-face, we might have more subs because more parents might be available. Just a thought, is that maybe
There's a lot of
probably
cause and effect for
possible reason why?
If you just look at the average age of our subs, they're in the upper part versus the early parent part who have kids in school, But again, there could always be more people that would be available. All right, thank you. I'm going to turn it over to Ms. Radcliffe.
Thank you so much.
Good evening. My name is Karen Radcliffe, and I'm the Executive Director of Secondary Schools. And this evening, I'm going to start with giving you some information, sharing some information with you concerning a survey that we conducted with all of our administrative and leadership teams over the past 2 weeks. We asked 6 pretty easy questions, and I'm going to go over those with you at this time. The first question was, I'm a principal at the following level. And we had 15 elementary principals and 10 secondary. Secondary principals are those in middle and high school. The second question was, for elementary principals only, do you believe that Dorchester School District 2 should return to a full day, 5 days per week, face-to-face instructional model as early as January 4th, 2021 for elementary schools only, regardless of county disease activity, as long as individual school numbers remain low? The answers were yes was 1, and 14 said no. And again, that is elementary only. The third question, and this was for secondary principals only, middle and high school. Do you believe that Dorchester School District 2 should return to a full day, 5 days per week, face-to-face instructional model as early as February 2nd for middle and high schools only, regardless of county disease activity, as long as individual school numbers remain low? February 2nd is the start of the second semester. That's why that date is what it is. For secondary, we had 1 yes and we had 9 no responses. The fourth question, and this goes back to the elementary group. Since you selected no to the January 4th, 2020, please select only one. And the 3 choices were elementary returns face-to-face on January 19th, elementary returns face-to-face on February 2nd. I do not feel that we should return full face-to-face. And the responses for elementary returning face-to-face for January 19th was 0. For February 2nd, face-to-face for elementary, again, that's the start of second semester, there were 5 responses. And I do not feel that we should return face-to-face. There were 9 responses for that one. And again, those are elementary. Another elementary, since you said no to face-to-face, if you had to choose, which of the following would you choose? Elementary returns face-to-face on January 4th, and that's the date we return from the winter holidays. Elementary returns face-to-face on January 19th, and elementary returns face-to-face on February 2nd. If you notice the first 2, face-to-face January 4th, it was 0. January 19th, it was 0 as well. Elementary returning face-to-face February 2nd. There were 9 responses to that. 15. Those were the ones that said no. kind of the odd wording. At this time, our last question, we asked our administrative teams to give us some comments as to why did they respond to those questions the way they did. So Ms. Estep is going to share with you some of the comments.
So yes, as Ms. Radcliffe said, we asked an open-ended question so that we could get some honest feedback from our administrators and their leadership teams, and just ask them to share any additional thoughts or comments as it related to returning face-to-face. For the next 3 pages that you have all of those comments listed. I am not going to go through and read every one of those. The gist, or to summarize, most of them mentioned feeling that right now it's with the disease activity and the trend upward, that they just did not feel comfortable, especially coming back after the winter holiday break, which is going to be longer than the Thanksgiving break, that would be a wise idea to come back after families had been together and had possibly been traveling. They also talked, as you go through and look at these, the phrase that stood out was regardless of county disease activity. They feel like that we have really worked hard these last 10 months to base a lot of our decisions on the data that we have, and to not use that same data now just did not make a lot of sense. There are a couple that I'd like to read out loud, again, because they sort of summarize the thoughts that I've heard the principals discussing, at least the elementary principals discussing, as well as the combination of thoughts that are on here. But you certainly have those in front of you to go back and read at your leisure. The current disease activity and rates should guide the decision-making. Additionally, teachers will need advanced planning time, and as we alluded to earlier, we are barely covering needs now with quarantines. Again, it's not so much the number of positive cases, but when you have a teacher that is out for 14 days because of being quarantined, and they may find out, they come in that morning and they may find out at noon that somebody tested positive and they've got to go home right then. It takes some preparation, and it takes some scrambling at the school level. I know I got an email from a principal on Monday that said, "Hey, Lori, just want to give you a heads up. We have 7 teachers out today, and we only have 1 sub to cover. We're making it work." And the principal, the assistant principal, the intern, the guidance counselors, and the media specialist were the ones that were teaching students and going in and making sure that students were getting an education. So it's real. A couple of others that I want to point out. We feel that the hybrid model has been working for our students, staff, and teachers. It has kept the majority safe. With recent virus spikes, we think coming back full face-to-face after the holiday break could overwhelm our system. Given time, possibly at the semester break, to transition back would give time for us to adjust schedules. We would also then know how many new students are going to enroll after the break. And the final one that I want to share, as the leader of the school, I have to support the school as a whole. At this time, I don't feel that we have enough information to make such a large decision with the current trend in our numbers. As numbers in the schools are not showing significant increases, but the numbers as a whole are. School districts are now discussing moving backwards in models due to rates increasing. Without having the data, still being a month and a half away, I stand with the pulse of my school. I feel that in order to make an informed decision, we must have the data to make that decision. We need to see how the numbers continue to trend over the next few weeks. My staff has shared many concerns with moving forward with the current conditions. So that sort of wraps up the teacher survey results. The administrative teams and the principal pulse checks that we did. Again, I would encourage you to go through and read the rest of those comments. We did have over 20 principals that responded and provided feedback, which was it was very interesting and in some cases enlightening to read. So another piece of data that the board requested was how are we doing? We've heard parents say this isn't working. We've heard teachers say it is working. So tonight we have some information to share since first quarter report cards have already gone out. And so we're going to take a look at,
Before we move on, a couple of us have quick questions
Okay.
about the teachers, what
Okay.
you've discussed. Ms. Farnsworth?
Thank you. And this, so my question's going back to the teacher survey as well as that admin survey, so they're probably admin related. So Elena, I apologize to bring you maybe back up. For our teacher population, for our educator population in DD2, and again, my guess is you won't have this data in front of you. You probably know it offhand though. I know we go through it in our annual personnel report. What is the average tenure of our teachers in DD2? Just
that's-
across the district?
That's a great question, and I actually do have that report ready, but we just haven't gotten to it yet. I don't have it off the top of my head, and I don't want to speculate.
That's
You know,
fine.
we know that new teachers in the profession nationally, some of them don't, 0 to 5 years is when they get out. If we can get them to stay in past 5, we have much more results. So I'm sure that's
And I
not-
promise, there is a reason I'm asking
sure.
the questions. Maybe before Monday, if you can just email us or let us know, because I'd like to know the average tenure of our teachers in the district, as well as the average education level.
And I do have all, and I
district.
probably can pull it up on my computer when I get back to
Yeah,
my
that's
seat,
fine.
because I do have that information from when we look at it, from last year's personnel report. We do the report from September 30th to October 1st, because that's how Sarah asks for the information, so that's how we track it.
Absolutely. And so then moving over to the admin side of things, same two questions. I'd love to know the tenure of our admin professionals in the education profession, as well as their education level. I know all of them are master's level or higher. The reason I'm asking that, because we now have the data from that population, and I think it's important for folks to understand who comprises that population. I think folks might be fairly impressed with the credentials and the tenure of the people who are telling us what direction we should be looking at.
Yes,
That's the
sir.
reason I'm asking those questions.
Gotcha. I'll get that for you.
Yep.
Does anyone have any more questions at this time before she leaves? I do just have a quick question.
Okay.
Just as with the students, I would just be interested to know how many teachers were out of school last year when there wasn't COVID this same time.
okay, we can
Just-
get that?
Thank you.
Yes. And I'm hoping
Anybody
somebody's
else?
writing that down. I was taking notes on everything that we needed to
I
get,
know,
but
I know.
we'll make sure
Thank
we get
you.
that for you. Okay.
We're ready?
Yep, very good. All right, we're going to now move into, as I was saying, the first quarter. We're going to take a look at the failure rate data in two different ways. We're going to compare last year's first quarter data for 2019, 2020, and this year's first quarter data from 2020 to 2021. So what you see on the screen or on your hard copy is that comparison for the elementary schools first. Those are listed in alphabetical order. The orange is the percentage of students with at least one F, one failing grade for the first quarter. So, and then the blue is the percentage of students with at least one for this year. So 2019-20 is in the orange, 2020-21 is in the blue. Okay. And again, I want to point out that I know, I said this today when we were looking at this, we don't want any of our students to fail. We don't like any student to make an F. And Ms. Radcliffe is going to, when she comes up and wraps up the part, we're going to talk about what we're doing about this, because we're not just obviously writing it off. We care about our kids. But it looked bad when I looked over there and I saw 2 or 3 of those blue bars way up high, but I encourage you to look at the percentages as well, because in some cases, it's the way that it's set up, that we're, 6.1 to 11.3. It's a 5% difference, which still is not great, but I think the bars make some of it look worse than they are. Okay, the next one that I'm going to share, we've had this question asked a few times as well. is if we think that our hybrid model is working, how is our virtual academy students doing? So this particular slide shows the students for this year, the percentage of failures with one, again, this is one, students with one F or more, that, again, the blue is with the face-to-face model, and the green is in our virtual academy model. That's correct. This is all data from this year on this slide. So the blue is for face-to-face students that are in the hybrid model right now, and the green is for strictly virtual academy students. Questions on the elementary before I turn it over to Ms. Radcliffe to go over the secondary?
Thank you.
Looking at the same type of information for the secondary groups, if you look at this first slide, this is going to be a comparison between the first quarter in 2019 and the first quarter in 2020. If you look at the bottom, those are the middle schools on the left, and the high schools are the three schools on the far right. The orange will be 2019 and 20, and the blue bars will be the 2020-21. And again, this is the percentage of students that have at least one failing grade on their report card for their first quarter. And like Ms. Estep said, you know, anything that we see that has a failing grade causes us an issue. We want our students to be successful, and I can promise you, between our administrators and our teachers, they're going to do everything in their power to ensure that their kids are successful. So, you know, to say that we're pleased about those numbers, no, we're not. And we know that we're going to do everything we can to rectify those. Like with elementary, we looked at the secondary level as well, between our face-to-face students and our virtual academy students. Same type of chart. The blue will be our face-to-face students, and our green will be our virtual academy students. And again, you know, anytime we see students that are failing that first quarter, that causes us a moment to step back and look at what we can do, what can we change, how can we fix, where can we remediate, where can we work with our students as far as scheduling is concerned, as far as work is concerned, technology, etc. And the next slide that I'm going to show you really looks at some of the interventions that we're using at all of our different levels. The one thing that I think we have seen especially in the hybrid level, is the one-to-one instruction. We know having a smaller group of students in that classroom allows for a lot of individualized attention for many of our students that really need it. So we see the one-to-one instruction. We know that we are getting extremely creative with tutoring, whether it's virtual tutoring, whether it's in the morning, whether it's during courtyard, whether it's during lunch, whether it's in the afternoons. We run what we call academic overtimes, the old-fashioned Saturday schools, where they come in on Saturdays and they have an opportunity to work with a core teacher, whether it's math, science, social studies, or English. And I will say, our kids take full advantage of that opportunity. At the high school level, we have evening schools that we run on Tuesdays and Wednesdays from 4 to 7 o'clock. And our students definitely do take advantage of those opportunities as well. Many of our students utilize what we call Focus Fridays, where we bring in a targeted group of students to get some additional work where they may need some help and work with teachers. I know at the secondary level, we work a lot with quarter recovery. We give our students an opportunity to remediate and retest. We give them an opportunity where they could possibly pass that first quarter grade through mastery learning, and I think that's extremely important for that secondary group. I think communication at the secondary and elementary level is extremely important with our parents, so they know exactly what's going on in those classrooms, whether they're virtual, whether they're face-to-face. Also, now with technology, we've got a lot of prescriptive remediation courseware that our students can use as well. And I know at the secondary and elementary level, we are using a lot of different programs. Differentiated instruction. And I will say, it's amazing to watch differentiated instruction now, even virtually, watching our students in the different groups, being able to break off and do group work through virtual work. Flexible scheduling with some of our students. We know that some of our students need face-to-face instruction and may be struggling in a virtual model, and we've been able to move them into a face-to-face model. Again, teachers working directly with parents, helping them identify what their students may need. I think that's an extremely important intervention. I will say a lot of home visits between our counselors, our administrators. There are a lot of home visits taking place, making sure that the kids are doing what they need to do, and how can we support these families. Also, academic and grading conferences, not just with teachers, but with our students as well. That's extremely important. So, like I said, when we look at a student that has failed at least one course, that causes us a problem. And we're going to do anything in our power to remediate and help prevent that to occur in the future. And we know at the secondary level, we do have a very strong prevention and intervention program. And it is moving full tilt right now for our students. Yes, ma'am. Please. Absolutely.
Thank you. As I was sitting here thinking, one of the things that I also want to add, just to let you know, and many of you may already know it, is that we had to, during LEAP week, we had to do a pre-assessment of all of our students, kindergarten through, I believe it was ninth grade. Camilla, is that right? Ninth graders had to be tested too? Thank you. Kindergarten through ninth grade, we had to do a pre-assessment. As part of the South Carolina Department's monitoring, we had to test again this month prior to the winter break. So we are currently doing our reading inventory and our math inventory, the assessment that we did back during LEAP. And many of our students, again, we don't have those scores yet because we have to wait until all of the testing is done. And the last day for testing this month is December 17th. So we will have that growth information sometime after we come back over the winter break. Mr. Schmink's department will put that together for us. But we are hearing from teachers, we're hearing from principals as the students are taking them, they are seeing growth. So that is something that's helpful. I know even my child came home the other day and was very excited that his Lexile and his quantile had gone up since August. So I wanted to point that out. The other thing that I think is important that we remember, and I was speaking with a reporter this morning, and she was asking about the failure rates, and she wanted to know what we thought, what I thought was the majority of the problem. Was it students not turning work in, they're not engaged, or what? And I went back and thought about this. At the beginning of this school year, we started out e-learning, 2 weeks of e-learning. Everybody knows we had some hiccups because we're starting out learning on student devices. Even though some of them had them back in the spring, we were mainly paper pencil packets. So there was a lot of learning to do on how to use the devices, not only from the students, but from their parents who were helping them, and also from the teachers. Just as soon as we got into the groove of e-learning, then we moved to hybrid. And so there's another model that everyone had to get used to. And when we first started the beginning of the hybrid model, we did 2 days at school, and then we did 2 days of e-learning, and then the teams on the Friday. And kindergarten through second were only the ones that were going that half day for a while. We didn't bring our third through fifth graders on to the half day every day for a couple of weeks after that. So I guess my point in all of that is first quarter was rocky. with different models and different things to learn besides the content. I feel now, again, based on feedback that we've gotten from the schools, that our teachers, our students, our families, they're into the groove now. They know, okay, where the elementary kids are going every day, they know what their schedule is, they know how to upload their assignments. So I just feel like, it took a little while just to get things shook out and where they needed to be. So we're hoping second quarter is definitely that we're going to see an improvement. And as Ms. Radcliffe said, we've got a lot of interventions in place that we're not going to let our kids fail. DD2 is too good for that. Ms. Crosby?
Parent,
Many times they go over those when they have the parent conferences. That's not necessarily something that we send out, though. Definitely, we share the information with them, and the kids get that information too. Like I said, when my child came home, he knew exactly what his Lexile score was. Some of the students track them in their notebooks as well. But as far as do we send out like what the state does, a parent letter saying what those scores were, we do not do that.
I would like to also ask, the interventions are wonderful, especially when you see the failing, which for all the reasons you've just said. You're offering these wonderful interventions, the tutoring sessions, the academic overtime Saturday, the evening school. Are all students allowed to participate in this, or is it designated by the teacher who does this? How would a parent know my child has this because?
You want to speak to high school, and I can certainly speak to elementary. Any time, again, that we have a student that is not performing at grade level, we certainly try to provide interventions, and parents are notified. The elementary students, really, the teachers communicate pretty much on a weekly basis. Again, all of the grades they can see in Power School or in the unified classroom. So, yes, the parents are going to know if they need to be in an intervention, that's going to be communicated. And I'll let you speak to the Saturdays and evenings.
Thank you.
And I will say, at the secondary level, all students have an opportunity to participate. And I will say, personally, I'm on a phone caller that gets sent out to all the parents, and it's on the email, it's on the phone caller as to when those dates are, what the times are, and the process to sign up. But absolutely, we want our students to be successful. So yes, the door is open for those interventions.
Do you have many that do come?
Absolutely. I think, and I'm going to use Ashley Ridge as an example. I just happened to see this number the other day. They had almost over 100 students at their last academic overtime on a Saturday morning.
That's good to hear.
You know, that's impressive for a group of secondary students.
Thank you.
One other thing that I will mention that we didn't put on here, the State Department also has a program called Engage South Carolina that is free to students. There was some criteria, and Ms. Radcliffe and I worked very closely on this with the principals. But the criteria really took a look at maybe students that weren't engaging, they had high attendance problems, they didn't, we noticed that they didn't engage during last spring. Again, there were 6 or 7 bullets, including that they may have been failing a course. And so 2 weeks ago, we asked the schools to put together their list of students, and we had to didn't have to. It was an optional if we wanted to participate. And of course we did, because we want to provide our students with every possibility that we can. But what the program does is they have coaches or mentors that will contact the families if the families opt to, even though we put the name on, the families have to opt to receive the help or to receive the support. And they will help the students via phone and go over things, whatever it might be. Maybe the families need some additional help with things that aren't necessarily academic. But our allocated amount for our district was 1,673 students that we could recommend. And so again, we received all of that information, the student names from each one of our 24 schools, and we provided those names to the State Department, and then they will reach out to those families to offer their services. So that's another intervention that's K through 12.
Thank you.
Ms. Crosby?
Are our teachers being compensated if they work on Saturday school or evening schools? Are they being compensated for that?
Yes,
Thank
ma'am, they are. Many of them are, but honestly, there's some that give of their time freely.
So I think you made an excellent point when you're talking about the transitions in the beginning and how difficult that was and could have added to this. Of course, we don't know, but it does make sense. So do you worry that if we have more transitions now, like if, let's say, we consider going back to e-learning and then coming back into hybrid and then moving, do you think that that could cause additional problems? Is that a concern?
Well, and I'm going to say two things. I think when we first started out with e-learning, that was new. Now I feel like our students, even if they're not 100% there, they have a very good understanding. They have those devices in their hand every day. We just recently had the e-learning day on Election Day, and we have another one coming up on next week on Friday. So I don't, myself personally, I don't anticipate there being as many concerns as there were prior. I feel like our students are used to the different models now and especially know how to use their devices and submit their work and know what the expectations are. And those relationships have been developed. That's another thing that we can't forget is that when they came back to school, they hadn't seen teachers, they hadn't seen their classmates for months. And so again, it just takes, it took a little bit of time to get used to what this new mode of learning looked like.
Sure, absolutely, that makes sense. And then one other thing, could you talk a little about how we're doing interventions in elementary schools?
Sure, yes. So our schools that are Title schools have Title I teachers, and they do that for reading and math. Again, just like we've done in the past, when we take a look at a student and we see that their RI is not where it should be, then we look at other data points as well, and they are offered that extra support. Same way with as we go through, again, we have MTSS teams. So when we see students that are struggling, they're not turning in their work, whatever it may be, those teams get together and they specifically come up with a plan on how can we help this child. Is this something that we've got to do a chart on that, we mark how many times they turn their homework in? Are they having problems? There's nobody at home to help them log in the afternoon. So it's sort of case by case with what students need. But the majority of that comes from we pay for title teachers, so it's face to face. They also, those teachers are also doing it virtually. Like Ms. Radcliffe said, when they see a student struggling, they'll offer to the parent, hey, we finished school at 1:45, but at 2 o'clock, I can jump on and show your student how to do this for 15 minutes. So it may be virtual,
Right.
but they're offering those
Because it seems like, they've got that limited time, 2 hours and 45 minutes, and so that's not a lot of time. If the interventions could be done at other times, it might be helpful for these kids who are having issues, like doing it outside of that.
And what they do too is within our literacy model and our math model, we have built in differentiation times. So especially now that we have half of the students in the class, when the teacher does her small groups or differentiation groups, she may only have 2 or 3 at the most students that rotate through to her. And so that's where a lot of the individualized, personalized time is coming, is from their actual teacher within that literacy model and math model.
Thank you.
You're welcome. Okay, other questions before we move on to our last part?
I know that the State Department has made adjustments because of all this and changed, just like about the end of the year testing and whatever, they've made adjustments for us. All right, we know that there's a DMP that is to be followed. And when they're only in school for 2.5 hours, and part of that's lunch and getting ready to come and go and whatever, how do we plan on catching that up to where they will reach that defined minimum program before the end of the year?
Okay.
If these people are not wanting kids to go back to school.
Okay, I'm going to talk about elementary, and then if Ms.
Yeah,
Radcliffe...
I was concerned about elementary.
Yeah, and then I'll let Ms. Radcliffe talk about the secondary. So again, even though they're face-to-face only for that 2 hours and 45 minutes, a lot of the transitions have been cut out. They're not going back and forth
Right.
to the lunchroom. So for the reading and for the math, when we talk to teachers, they're actually pretty much on track with the pacing because they're able to move through at a quicker pace with less students, with less discipline problems, with less transitions. In the afternoon, just because they're not in school doesn't mean that they also do not have things that they are working on. So many of our instructional technology programs are done in the afternoon. The science and social studies we embed within the lessons, particularly in reading for the social studies, and for math they embed the science because those are aligned. That's not to say, Ms. Crosby, that we still have things that we need to get through. We do, but right now we're not seeing that they are so far lagged behind that we're not going to be able to catch up. The teachers are focusing on those essential skills. Maybe some of the extensions are not happening at this time, but they're really working on the basic skills and those focus skills. And then when they go home, that's where they do the practice. That's where they do the extension. So that the direct instruction is happening for those 2 hours and 45 minutes. As far as the defined minutes, obviously, you're right, the State Department has given some waivers, and so we look at that as the 2 hours and 45 minutes. That's actually face-to-face. That is half of the time, half of our school day. And so we're meeting the letter of the law for that for elementary.
Okay, and the, never mind. Never mind.
Okay, if you think of it later, just let us know.
Well,
Ms. Radcliffe, did you want to talk about secondary with their?
I'll just touch briefly, because really, Ms. Eastep touched on it already. It's about standards. At the secondary level, it's about meeting those standards. And I will say right now, in our programs, in our courses, we've got pacing guides that our teachers follow. And right now, they're pretty well on target for what they need to do. And they are looking at very specific standards. They're having to cut some of the fat out of the program, and our students are responding. And again, when you have 14 and 15 students in your class instead of 28 and 30, you can continue to move at a very respectable clip, time frame wise, because you've got 15 students to focus on. And I think that makes it extremely important. So we are following our pacing guides, and we seem to be right on target right now.
Can I ask, would everybody like to take just a 10-second stand-up break? Let's do.
Need some
Okay,
Go
just
Noodle
maybe for 10
policy
seconds. Stretch. Thank you. I hope that helped everybody. It sure helped us up here. And at this time, we will end our stand-up break and stretch and move on.
don't we have a guest speaker too, Ashley? I hope he's patient.
In that quick little 10 seconds, I got a couple of updates. The defined minimum program has been waived, and that, again, even though that's not at the elementary level, secondary, that's that's not there. I also heard that we are doing tutoring with our Title I students as well after school, and there was something else, but it's already left my mind. So if I think of it, Ms. Crosby, like you, I'll go back and talk about that in a couple minutes. Again, we're going to move into the last part of our presentation, which is taking a look at our 4-phase model. When we first started talking about what is it going to look like to transition from the current model that we are in, which is hybrid, back to face-to-face. You know, I think in some people's minds we're like, oh, well, that's easy. Everybody knows how to do face-to-face. That'll be the easiest transition we have. Well, when we start taking a look and we start talking about it, we really don't think anything's ever going to be normal face-to-face again, because, again, we're still in a pandemic, we're still wearing masks, even if we would move face-to-face. So what we decided, you know, when the large group came together and we started doing the planning, is that we just brainstormed, list all of the things that we are going to have to think about and make sure that we have planned for. And so what I'm showing you just as a snapshot up here is this is phase 1 and phase 2, just a picture. I'm going to come back after we go through our process and sort of our logistics that we went through and show you that this is the 4-phase plan, or the 4-phase model is what was the culminating project at the end of what we came up with. But phase 1 is where we are now. We are currently in hybrid, and all levels are there, so elementary, middle, and high. So just sort of keep that picture in your mind and know that we're going to come back to that at the end. So hybrid and face-to-face is what we're going to take a look at. When we look on the left, you're going to see all of the brainstorming topics that came up. So you see instruction, you see supervision, you see social distancing, you see class size, you see restrooms, substitutes. We started out doing the brainstorming list at the district office, and then we had a principals meeting, and we asked the principals, what have we forgotten? Please, you know, you're at the school level, tell us what we aren't thinking about. They added to that checklist, and then they also asked teachers, you know, what things are we missing? What do we need to think about? So when you look at what we have on the screen, I think you have 3 different slides in front of you. I'll just go through a couple of these as examples, again, rather than take the time to read through. But of course, one of the biggest things that we have to think about is the social distancing. Right now, we have reduced numbers of students in the building, which means that we have reduced numbers of students in the classroom, which allows us to really do the social distancing very well. So we're 6 feet apart, students are wearing masks, less students, working beautifully. We move to full face-to-face. We bring all of our students back into the classrooms. Some of our classrooms, that's not going to be such a big deal. They've got 22. They can fit them in with the plexiglass. We have to be 3 feet apart, so that sort of helps us out with that. But we do have large classes, particularly from 4th grade on up through middle and high. I know that we have at least one elementary 5th grade class that is at 31. And so when we started thinking about that, we've got to look at, okay, does that mean we have to move teachers around and divide the class? Does that mean that we have to find a larger classroom, such as the media center or possibly the multi-purpose room, so that they can still socially distance? Again, it's not as easy as, okay, just bring all of the students back. So that's just one example. Right now, we talk a little bit about transitions. In the elementary school, we're not doing a lot of transitions. For the most part, the students stay in their classrooms. Lunches are brought to a certain area in the school. They go out into the hallway, pick it up, or it's delivered to the classroom. They don't need to go to the cafeteria. They eat in their classrooms. They're not going to fine arts. Fine arts is fine arts is held in the afternoon or in the morning on their time that they're not face-to-face. It's held virtually. So we haven't had to have a lot of transitions. When we go full face-to-face, again, that's going to be something that's different. So again, I'll let you scan down through the topics, but for each one of those that we've listed, it definitely involves some preparation and some planning for going back to full face-to-face. We put down at the bottom, just as a note, we kept talking about the social and emotional learning because, again, we all know that students are very social beings, and this has been hard for a lot of them. They want to be around their friends. It's very difficult when they're on teams to really have the interaction like they do face-to-face. So the more we talked, we felt like the social and emotional needs sort of fell in everywhere up there. So we just put a note at the bottom that we would continue to respond to the social and emotional needs of staff and students for all of the instructional models. So the next step in doing this, after we took a look at what the changes or the preparation might be, it obviously led to, okay, how are we going to do that? This is going to be a challenge. So I'm going to turn it over to Ms. Radcliffe, and I'm going to let her go through, as we plan to move to face-to-face, what some of those challenges are going to be.
Thank you. We looked at this as a group of elementary principals, a group of secondary principals, and looking at that same checklist that Ms. Estep just showed you with the face-to-face, or excuse me, the hybrid and the face-to-face, we looked at that same checklist and we wanted to know, okay, let's look at the planning pieces. Where are some of our big challenges going to be, and how are we going to address some of those challenges? And I know at the secondary level, I can feel the secondary group looking at me, that probably one of our greatest challenges is our master schedule. If anybody knows anything about a master schedule, it is an enormous puzzle. And what you do for one piece, if you move one piece of that puzzle, it will change 10 other pieces of that puzzle and mess it all up. So you've got to be very, very careful in what you do with that master schedule. And we know that when we go back face-to-face, we're going to have to make sure that all of our classes are balanced. We know that there's going to be a group of virtual academy students that are going to be pushing back in. We also may have a group of face-to-face students that may be pushing into the virtual academy. Well, that's going to wreak havoc in a lot of our classes. So we're going to have to be very intentional in how we schedule, because we're going to have to change some teacher schedules and move some pieces and parts around in that master schedule. And the same thing can be said at the elementary level as well. When you're looking at balancing classes, there's a good chance that you're going to end up moving some of your students out of a classroom. Like, let's say in a first grade class, if you've got to balance that class out, you may have to move 5 students away from the teacher that they may love. And that's going to be a problem, because elementary students don't like a whole lot of change. Not the secondary students like a whole lot of change either. But that's going to be a struggle at the elementary level. Also, balancing classes at the secondary level is going to be tough, because we've got large classes. Our classes can go anywhere from 15 to 32 right now. So we know that whole socially distanced thing it can't happen, simply because our classes are so large. We can't move our desks 6 feet apart. We know that. Also, and you're going to hear after this about our plexiglass dividers in our rooms. Again, we can't guarantee socially distancing our students, but, we are planning to put plexiglass dividers in our schools. One of the issues I know at the secondary level that worries us is, how do we clean those? We've got 5 minutes in between class changes. How do we clean those plexiglass? Are we expected? Is that one of the protocols that we're going to be expected to do, and how are we going to do it? So that's a challenge, especially at the secondary level where we are transferring and moving, transitioning kids from class to class. Another challenge, and I'm not going to go over every single one of them, is transportation. We know right now that the State Department says there's a cap at a 67% capacity on the buses. So for us, that's about 42 students per bus. So we need to make sure that all of our routes do not have more than 42 students on those routes. And again, that's for face-to-face. If we bring all of our students back, we need to make sure that we can maintain less than 42 or fewer students on that bus. The last two, and really I believe that Ms. Fenari touched on these, I think our substitute coverage always concerns us when we look at going back face-to-face, because it's going to require us to do a lot more supervision, and I think we're going to struggle with that in the area of substitutes. Also, adequate staffing. I think that's always going to be a fear for us right now, looking in these difficult times. So going back face-to-face, those are some of our major challenges. But again, we've got the spreadsheet in your presentation. Any questions about those?
Ms. Radcliffe, with the virtual school, academy going on, would that help with the bus attendance?
Yes, ma'am, absolutely, that certainly does. And quite frankly, we've already looked right now. We took a snapshot of a day or two, looking at our A cohort and our B cohort, and looked at how many students are actually riding the bus. And I know at the secondary level, we only had 2 buses that were sitting right at 42 students. So that was not bad at all, and I don't think.
I think we've got 2 also, but then again, when we look at, I think we have 2 also right now that are approaching being at full capacity. We're running some double routes already, and when we spoke with Mr. Shope, that may end up having to go to triple routes if we don't have enough buses, if we have students come back. But the virtual academy numbers certainly are going to play a part, depending on how many students come back or want to come back, and how many of those students come back at certain schools and in certain grade levels, and for the buses in certain geographical areas. So again, it's probably doable. It's just a lot of planning and a lot of work once we get those numbers, so that we can start looking at, okay, how are we going to make this, like Ms. Radcliffe said, it's a puzzle. How are we going to make this work?
Thank you.
And I was just going to say that these are definitely some serious challenges. So my question is, if we stick to the plan and wait till the DHEC levels in our county are low to transition back to full-time face-to-face, what of these challenges will we still have? Because probably a lot of them. So they're going to have to be, I mean, it's going to come probably no matter what. At some point, hopefully, at least we're all praying that, right, that we're going to get back to low.
Absolutely, and for us, it's about time. In order for us to transition, we need time. We need to know, for us at the secondary level, it's about 3 weeks' time that we need to know when we're going to transition. If we transition back face-to-face, we need to know what we need to do to move our virtual students, whether they're coming back face-to-face or some of our face-to-face moving virtual. We need that amount of time in order to give our administrators to have to schedule it.
Sure, I totally understand that, but we could, I mean, we're obviously not going to drop into low tomorrow, but I mean, that could happen.
Sure.
And so will we be ready when it does? I mean, I completely understand the need for time, yes.
And that's it. That is the great variable for us, is time.
But if we got to low, you would feel confident that we could go
Yes,
back, that
absolutely.
I mean.
Yes, with a solid 2 to 3 weeks, we could make that transition.
You're saying we'd have to wait 2 to 3 weeks
I
once
would
we were
say-
in low?
I would say at
Because-
least 2 to 3 weeks to allow the rebuilding of that master schedule and moving our kids.
Once we get to low, we still would need to wait 2 to 3
Well,
weeks.
Once the plan is put in place, we will have to roll.
Right.
Ms. Radcliffe, excuse me, Ms. Radcliffe, the buses right now, we've also asked people to try to carpool.
Absolutely.
Bring in cars. So have y'all seen that's making a difference too?
Yes, ma'am. That's making the biggest difference right now, is we have our car rider lines are considerably longer than usual.
Okay, the other question is, Mr. Pye had said at the midterm, which is February the 1st, you said, or February 2nd?
February 2nd, yes, ma'am.
Okay, that at that time, students can make the transition if they want to make it, regardless of where we are, right?
Yes, ma'am.
So whether we're hybrid or full-time, whatever, so that
Correct.
transition is going to take place regardless?
Yes, ma'am, correct.
So that could also affect the classes, da-da-da-da-da?
Absolutely, yes, ma'am.
So it's not,
Certainly.
so it's not just a matter of changing?
I don't think that's in blood, though, is it?
They don't-
Well, excuse me, correct. If there is space available. And we've got the list of students that have, that made that request at the elementary level and at the secondary level. I think the secondary level, the information isn't due until January 8th. But yes, given if space is available.
And you've already got one-off cases right now where you're shifting students from hybrid to.
Some of our very serious cases, yes, sir.
But have you got the number yet, from Ms. Eastoe?
Yes, we have the numbers. That's actually what I was going to bring up, is that we asked, because we knew that we were moving to that at the end of the semester, we asked for elementary to please have their letters of intent into us by December 6th. If a decision is made that the instructional model is going to change, we have had several parents ask, well, then how can I make a decision? The difficult thing and the challenge with that is the more we cut our time in planning how we're going to move teachers around, because if we have, and I'll give you a perfect example, when I looked at the data the other day from Dr. Harrison, he and his secretary updated on a daily basis the number of students wanting to come out of virtual and the number of students wanting to go in. And they have that by grade level, by school. I had one school that has 14 students that want to come out of virtual in the 4th grade. The virtual teacher for that 4th grade, there's 2 virtual teachers. One of them only has 17 students. Well, one of those teachers is going to have to move back to face-to-face. And the 3 or 4 students that don't want to come back then are going to have to move to another teacher. It's just, again, that's what Ms. Radcliffe is saying. It takes a lot of time to lay it all out, to work with personnel to see what teachers can actually teach, because in some cases you can't move an elementary teacher that's in 2nd grade to 5th grade if she doesn't have the certification, but that may be the only place that there is an extra teacher or someone that we can collapse a class. So the more we shorten that time period to where, okay, we've got everybody now calling in and now they're all wanting to change, that just sort of upsets the apple cart and we go back to square one.
Mr. Souls, you ready to talk about some plexiglass?
Good evening. Just a brief summary of where we are with the plexiglass installations, and before I start on the page where we've got the numbers, you see that there's a lot of plexiglass in our district now. And the blue tape is actually serving a couple purposes. For visual purposes, as well as to protect the sharp edges. When we look at the desktop units for the elementary schools, this is a live document. It's ever changing. We had 2 schools in progress today that we're getting ready to complete, and I got a text about 5:30. Windsor Hill is finally complete with the desktops and the standalone units. So everybody's going to roll over to Somerville Elementary tomorrow and finish that school up. We have some elementary schools or 10 that have additional requirements that they identified. Those units will be installed next week. And on the stand-up units, the standalone units, we've got 3 schools that are still in progress. Well, 4, but there's 3 that the contractors or the vendors are going to install for us, and they're working on those tonight. Eagles Nest, Sand Hill, and Span, they're working on getting those installed And we're going to take that little number at span and do that ourselves in-house. But just to give you a big picture view of what's going on, our personnel have handled 6,200 pieces of standalone plexiglass.
Wow.
6,200 units have been installed. 4,434 desktop units have been touched by district personnel since the 1st of November. At the middle school level, once we get the elementary schools knocked out, we're going to roll over to the middle schools, and some of the middle schools are even jumping on this and handling it themselves, which I applaud them for having the wherewithal to do that, and I appreciate their efforts. And that's all I have.
You are amazing. Thank you. You and your department.
Well, thank you very much. It's a team effort. I will promise you that.
Mr. Farnsworth has
Just
a
a very
question.
quick question, and this is probably for Ms. Santamaria. With the plexiglass, so as far as DHEC and CDC guidance, does it drop down? So the 6-foot social distancing is the normal requirement. With the plexiglass, is that true that it drops? So does it drop down to 3? with
It
the
does,
plexiglass?
as long as the plexiglass is the appropriate size, which these units are, and they're used in the appropriate manner. So the students are still spaced 3 feet apart from seat to seat, and it covers at least a foot above their head and extends out on 3 sides.
Gotcha. Thank you.
You're welcome.
Anybody else? Thank you.
Thank you.
Okay, so coming back around, I told you we would come back around to our 4-phase model and take a look at the specifics. So as I said, when we began this section, we are currently in what we call phase 1, which is our hybrid model at all levels, elementary, middle, and high. And just as a reminder, we've been in the hybrid model for a while. There's been different aspects to it where we've brought in more students a little bit at a time, such as we started out with K2, 5 days, half a day, and then we added the 3-5. So that's all been part of our hybrid model, just sort of different phases of it. What you see on the screen, again, is if you think about that checklist that we've taken a look at and all of those things that we had to think about, this is what we came up with for the current hybrid model, where you can see I'm just going to take the meal service program. Right now, we're doing grab-and-go breakfast, and lunches are being delivered to common areas for pickup, and then they return to eat in the classroom. We found that that's what we feel is the safest way for us to do that, rather than having kids congregate in the cafeteria or stand in line in the cafeteria to get food. And of course, Sodexo boxes or bags, all of that at this time. We're not doing field trips. We're doing virtual events wherever we can, and our schools have been amazing at what they've come up with in order to do virtual events. And we've actually had, I've heard several schools say that we've actually had, in some cases, more parents attending virtually for some of our events than we did when we used to have them face-to-face. So there is a silver lining in some of this. Again, I'm not going to go through all of these, but each one of those represents a discussion that we've had to have and that folks have had to come to consensus on for what we are going to do in whatever particular model we're in. Our second phase would be when we move the elementary schools to face-to-face. We would stay on our current daily schedule of 7:15 to 1:45. Obviously, we would continue to have the isolation rooms for symptomatic individuals. Right now, the 67% ridership capacity on buses, that has not been lifted. So in phase 2, which we just talked about prior with some of our challenges, that's still going to be a challenge until the State Department lifts that and allows 100% students back on the bus. We mentioned a little bit about the Virtual Academy transfer plan, and you can see we have those dates up there where we ask for the elementary students' intent forms to be turned in by December 6th, and the middle and high school's intent to be turned in by January 8th, since they have a little bit more time. Obviously, we've discussed if the instructional model changes, we're going to have to go back to the drawing board and see what we need to do, because we certainly don't want to exclude any of our parents. We've talked about giving an extra 24 hours once possibly a decision is made for them to go back in and change their minds to get it in, and we would hope that that still gives us time, because we've been looking. It's not like we're sitting waiting on numbers. As I said, Dr. Harrison and his secretary update their information on a daily basis. That's available for principals to look at. I know they're looking at their class rosters every day and going, okay, we got one that needs to come into the school and we've got one that needs to go out. Thank goodness they're the same grade level, so that's an even swap. It's not always that easy though, but they are looking and planning. So again, just all of those things that we need to take a look at and make sure that not only that we've got a plan for it, but that it's clearly communicated to our families so that they know, okay, we're going face-to-face, we're going to make sure that we're still following all of the safety protocols that we can. We need to communicate it to our schools so that they know what the expectations are. So again, I can't say enough how much planning goes into this. It's not just as simple as, oh, great, we get to go back to face-to-face. I'm going to let Ms. Radcliffe talk about phases 3 and 4, and then that will pretty much take us to the end.
Can I ask a question about 1 and 2 real quick? Is that
Yes.
okay? Okay, so on phase 2, it says recess protocols will remain the same as in phase 1, but we're not having recess right now in phase 1,
We are.
correct? We're having recess?
We are.
at the
They go out.
middle and high, I guess
Oh.
middle. Elementary is not having recess, are they?
Elementary students are going out. If they go outside, they have very specific areas that they have in place. Again, 6 feet social distancing. They are not using the playground equipment, the slides and everything. They're not getting on that. But yes, we are allowing our students to get some
To have
outside time unless it's below 40 degrees, and then that's not
Okay.
happening.
Do you know how much, approximately how much time of the day that is? I'm just
About 20, they're trying to do 15 to 20 minutes.
15
Sure.
to 20 minutes of recess. Okay, I did not realize that.
Right, for the full day students.
Oh, no,
Not the
okay, I'm
half
sorry,
day.
I was
I'm
talking
sorry.
about the hybrid students, yes,
Okay.
that's where, yes, I apologize.
Okay.
For the hybrid students, they're not
Thank you,
doing,
Ms. Blanchard.
okay, yeah, thank you, yes, thank you.
It's okay.
So
No,
no,
I
that,
appreciate you
yeah.
jumping in.
Right, so they are not doing,
No,
okay.
because again,
Right, of
they're
course,
only
that's
there
what
2
I was
hours and
thinking.
45
Yes.
minutes. I apologize.
Right, no, that's fine. So that's guess where my confusion was. So when we move to phase 2, all the students will be following what the current all-day students do for recess right now. I was just trying to imagine what recess would look like
Right,
for
and-
these
and
kids.
in our last principals meeting, they were, the principals were doing a great job of sharing ideas of, okay, we've got to section off this part, and this is going to be for, this particular grade level or grade levels, and we've got to make sure that we're alternating so that there's not too many students outside at the same time. They got to make sure they're still wearing their mask unless there's, again, lots of planning, but again, we feel like, if we're going to go back, the students need to have some downtime
Sure.
if they're going
Yes,
to be at school all day.
Definitely.
So, thank you.
In looking at phase 3, we're talking about the middle and high school group coming back full face-to-face. And much like phase 1 and phase 2, again, we're still going to have our isolation rooms within all of our schools. Our middle and high schools, we're not going to change the bell schedule. Right now, for middle schools, it's 8:30 a.m. to 3 p.m. The high schools, Gap and Rawlings, they're 9:30 a.m. to 4 p.m. We're not going to change that and go back to last year's bell schedule. Those are still the same. Of course, face coverings are still going to be required for all. I think the one thing that we need to really understand is, again, that whole social distancing is certainly going to be encouraged a great deal, but it cannot be guaranteed. And I think that's a hard pill to swallow for some. Meal program, again, we're still going to be serving lunches. It's going to be bags or boxes, and they're going to be eating in the classroom, much like they have already been doing so far. Our buses are still going to have to run at the 67% bus capacity, so that's still something that we need to be aware of. Of course, plexiglass, and you got your update on the plexiglass. Lockers will not be used. We're still not going to be utilizing our lockers. And again, we're still going to follow our same visitor protocol by appointment, and everybody must have temperature checks. Phase 4, I think phase 4 is what we so want to get to. That is full implementation with no restrictions. That's 100% capacity in all of our classrooms and all of our buses. You almost want to put in quotations, normal. But I don't know if we'll ever truly get to normal at this point in time. But those are the 4 phases that the entire team has really worked hard on to look at what those transition pieces are going to look like. And there is no doubt that we have given you a lot of information tonight, lots of things to consider. But we do want to leave you with one final thought. And this thought came from Accelerate Ed report that established really the following statement as the first principle for schooling during COVID. While scheduling should always seek to provide students with the best possible learning experiences, greatest priority must be given to ensuring the health, safety, and wellness of students and staff. This requires aligning all scheduling decisions with the latest recommendation and guidance from public health officials and monitoring all data points available about best practices for preventing the spread of COVID-19. I appreciate your time. I appreciate all your questions that you've asked us.
Well, we appreciate the time you took to prepare this for us. We can tell that this was very complex and very time-consuming, and we needed it. People out listening to you tonight, and there will be hundreds and hundreds, needed it. It's answered so many questions, and we, from the bottom of all of our hearts, we appreciate you. I'd like to just give you all.
Thank you.
To finalize the workshop this evening, Ms. Wimberly served on the safety task force with me before it shut down, and we were not able to have it, and it was a strong group, but she is still considered on that safety task force, and she comes from a family of medical folks, as she also is a pharmacist. So I tasked her with the responsibility to please find someone from the outside of the district, preferably a medical doctor, who maybe was in a hospital, or I would let her decide. And she has done an amazing job finding this wonderful individual. And I'm going to turn it over to you, Ashley.
Thank you. I'd just like to say that I, like Tanya said, I do have a, oh, is it on? I think it's on. I do have a medical background. I am a pharmacist, as many of you know, and so data and facts are very important to me. And in addition to that, we are receiving many emails and phone calls and lots of responses from teachers, parents, and concerned community members. And we're hearing all different things. One thing I think that I've noticed in all that, one thing that's consistent through everyone's concerns is that they all want us to follow the data, look at the science, and that to me is, I agree 100%, and that's what I want us to do. The presentation that we just had from the district was wonderful. I'm very thankful for all that data, and it's great. But just to follow up, I did reach out to several medical professionals. I spoke with several physicians. Before I mention and introduce the individual who's here tonight, I also want to say that I spoke with 2 physicians at MUSC. A pediatric infectious disease doctor and also a pediatric critical care doctor. And they, I actually had a Microsoft Teams meeting with them yesterday. We met for over an hour and a half, and they had lots of great information, and they are interested in coming and presenting to us too. One of the things that they talked about was the testing. I know we all have heard about how our state is going to be rolling out testing, and that's coming into our schools, and they had a lot of good things to share about that. And I think they'll have some valuable information as well. So my hope is, and I've spoken with Mr. Robinson about that, we'll be able to have an additional workshop workshop in January just to have them in. They're excited to come in and present, and so I think that will definitely be in our future as we continue to just monitor what's happening, gather data, and get as much information as we can, which is what we all want here, and all of you out there listening, I know, and all of our district leadership. That's what everyone wants, and that's what we're doing, and that's how, that makes me feel really good. So moving on, Dr. Lee Biggs, who is joining us tonight, is the Chief Medical Officer for Trident Health, a 437-bed hospital system that includes Trident Medical Center, Somerville Medical Center, Moncks Corner Medical Center, and Centerpoint Emergency. Prior to joining Trident Health, Dr. Biggs served as the Chief Medical Officer of HCA Healthcare's 334-bed Eastern Idaho Regional Medical Center in Idaho Falls. Dr. Biggs is a retired captain in the United States Navy. He has also served in a number of clinical and leadership roles, including the Chief Clinical Officer, Chief of Staff, and Chief of Surgery at naval hospitals in Naples, Italy, Guam, Virginia, Afghanistan, and Naval Hospital Beaufort in South Carolina. A native of Asheville, North Carolina, Dr. Biggs earned his medical degree from Philadelphia College of Osteopathic Medicine and holds a master's in public health from George Washington University. He completed residency in OBGYN at Naval Medical Center, Portsmouth, Virginia, and is board certified by the American Board of Obstetrics and Gynecology. He has completed a fellowship with the Joint Commission and is a certified physician executive with the American College of Physicians Executives. I reached out to Dr. Biggs, and he was so patient with me and spoke with me for a long time, answered all of my questions, was wonderful, and provided me with a great deal of information that I knew we needed him to share with us, and again, everyone listening and our leadership team here. So I asked him if he would come, and he was very gracious and offered to, and so we appreciate him, and we also appreciate his patience tonight, because I know this has been a long evening for him waiting, and thank you so much.
Thank you very much for that, the invitation to be here and for that introduction. And I've always thought healthcare systems were significant taskmasters, but now I recall teachers and school systems and school boards are equally as talented in that endeavor. So I'm not going to talk about classrooms or plexiglass or a lot of the data that you've been mulling around tonight. I really want to let you know what your region has been encountering on what I would call the sharp edge of COVID-19, or the acuity that comes along with all these positive tests that you've been hearing about. So these are the things that we decided would be good discussion topics of what our experiences have been beyond tests. What all goes into what I would call the burden of COVID-19, which is hospitalization rates, acuity of those hospitalized, and what we're looking forward to right now are maybe some of the bright spots on the horizon where this pandemic will come to a conclusion. And then we'll talk a little bit about the school system considerations that you've all been discussing tonight. I've done these talks to business groups and civic groups in the area many times. And I always start with this slide because this is what we all considered our surge one, and that's essentially June, July, August of all the new cases in South Carolina. And I start here because it takes me to this next slide, which is COVID-19 has really shown the alignment or the opportunities with public policy and public health policy, and they're either synchrony or asynchronous nature. And so what you're seeing on that slide is the governor opening the state on the 5th of May, and then roughly on the 23rd of June, the various masking ordinances and social distancing that the 3 municipalities enacted. And so I show that because it asks the question, what would have happened if ordinances were in synchrony with reopening? Would it have changed things? Would it have shortened that curve? And the other perspective is, did those masking ordinances that occurred in June actually help to flatten that curve sooner than perhaps it would have on its own? We're not going to know that, but it asks us to ponder that question of public policy and public health policy, how they will forever be linked, I think, going forward in this post-pandemic world. And this just shows you county-level data. The blue bars are Charleston County that had the highest number of cases at one point in Surge 1, followed by Berkeley and Dorchester counties with those same data points. And this kind of brings it to another point. Those first slides showed the number of cases. What you see is that second curve is the peak for most of that surge one of admissions was around the third week of July. The peak of mortalities occurs roughly 10 to 14 days after your super sharp peak of cases. And that'll come into play when we talk about where we are current state in the region. Now, this is our healthcare system. Our healthcare system, as was mentioned, is 3 medical centers and a series of acute care areas. We have not been in the posture in this pandemic of offering wide-scale screening, drive up, drop in, whatever. Individuals present to us with COVID-like symptoms or a need to be tested, and that's what has been driving our testing strategy. So if you see where we've been, there's that surge in the June-July timeframe, and that's what we're looking like right now for November as we go into December, and we'll see this data a little bit further articulated further. Now, who have been our patients? Well, they've been your community. And as we have heard, the story of COVID is really a story of disproportionate healthcare delivery and underserved communities. The African American population has suffered larger than any other subgroup. And then secondarily, the Latino Hispanic population that I think we don't fully account for in the region, but do all the key and critical jobs that their losses and their function definitely affects the economic ability of the community. And we stumbled onto this by accident because we saw the initial surge, we had 4 Hispanic gentlemen all simultaneously advance into our critical care ICU, and as the 4th one was about to be intubated, he asked how his roommate was doing. They'd all been registered as separate addresses. And doing source contact tracing, we come to realize they were all actually roommates. And that led us to a huge cluster in the Goose Creek area of Hispanic, Latino migrant populations that what we saw, there had been very little bilingual education to that community. There was zero awareness of the risks of COVID, and so we reached out to Spanish language media groups and print groups to do what we could to shape that outcome. And so it speaks to that, also that underserved population and minority in your community that is driving a lot of this disease burden. And then the gender breakout is really not necessarily different or new. Now, who are the COVID individuals? Well, I like to think that 40 to 49-year-olds are young people, but it is young people. That's the distribution in our healthcare system of who is getting COVID-19. And the greatest numbers are your ages, your 20-year-olds through your 50-year-olds. Now, who's obviously suffering the burden? Well, it's a 70-year-old and up that has the highest mortality rates in our healthcare system, which is what we've seen. By month, that's what we've seen. Obviously, July, we had a run of 24 mortalities in a 5-day stretch in July. That was when most healthcare systems were at the breaking point where acuity was quite high. We began to trend down in August, and we continued so with trends into October, November, and where we sit presently in December. Now, we talked a lot about testing and the positivity rate of testing. Well, this is our data, and what that's really telling us right now, if we look in July at the peak of the surge, individuals that walked into our facility, 35% of them were testing positive. Where we've been as we've come down off of that curve has been ranging in the 11 to 12.5, or where we sit in December at 13.9% positivity of all comers that are presenting for testing in our healthcare system. Now, I juxtapose that to, okay, you're a COVID positive, but are you suffering enough disease burden to require admission? And that's been the run rate. So right now, we're seeing about a 30% of those who test positive actually require hospitalization. And that's an important number, as we're going to see here in a minute, as it relates to all the hospitals in the state of South Carolina. When you look at July, where we had almost 1,000 individuals that we had admitted, that conversion rate was 36%, but the number was incredibly high, and we already talked earlier tonight about percentages, and you can add, you can change, but that metric right there is telling you disease burden. Who is terribly sick enough to require hospitalization? As you can see, post-July, we've had a variable run rate. Now, the story in April, we didn't have local testing, and very few people did at all. So if I wanted to test somebody, I had to call a DHEC public health nurse, pitch the story, and then about an hour later, a physician from Columbia would call me back. I would pitch the story again, and about a 3-hour turnaround, I would get an answer if I could test that individual. Parallel that to today, where you can walk in a multitude of platforms and be tested with either a rapid or a more sophisticated test, and you'll get an answer. But the story of testing has evolved in our country as the pace of the pandemic and the ability to test and identify and source contact trace has improved. So a lot of the data from March, April, May, and even into June is a bit misleading in terms of your percent of positives being admitted, because you essentially had to be admitted to the hospital to get a test early on in the pandemic. Now, this was an interesting story. I found it fascinating about the burden of students and teachers in the healthcare system. Well, healthcare systems have not been immune to this at all. But I'll tell you, of our nearly 3,000 employees in Trident Health, I can count on 3 fingers the number of employees who have been infected by a COVID-positive patient. And I'll pivot to the why here shortly, but these exposures, the exposures that we've been seeing, particularly November, there were a couple of weeks in November where we had actually more quarantine healthcare workers than we had COVID patients hospitalized in our healthcare system. So what that tells me is this disease, like you all have been discussing, is moving in your communities, in your schools, obviously, in your restaurants, in your places of business in ways. But the lesson on the healthcare worker side is that PPE, masking, distancing, symptom awareness, hygiene practices have worked in healthcare. Because we've not, handling COVID patients every day, we've not had massive amounts of healthcare workers lost. It's come from their lives outside of their profession. And that's an important take-home point. Now, what have we learned? Well, when this began, we sent out daily newsletters to all of our employees, very transparently, who we admitted, what our mortality rates were, and we could tell our physicians that COVID patient that gets admitted to a medical surgical floor, at day 4.5, they'll face their highest mortality rate. If they're in the ICU, it'll be day 9. So we were incredibly transparent to engage in conversations, because this was a time when patients' families were not allowed into the facilities. So you were having to make end-of-care decisions using technology platforms that most of our providers were not familiar with. Your region, even though we didn't talk about it every other day, MUSC, Roper St. Francis, Trident Health, the VA, and East Cooper held phone calls. My counterparts and the hospital CEOs, we talked about what we were going to do, what surgeries would we curtail, what entrances would we close, so that there was not a single individual in the Low Country that would have a different experience of care. It would be consistent. And these are all relatively competitive healthcare organizations that want to provide the best health care to meet their needs. But that was not happening during the pandemic, and it still to this day is not happening. PPE, as I touched upon, the right mask for the task. A lot of our healthcare workers felt they needed N95s. That's not the case. And had concocted many of their own masking strategies. And so there's a lot of freelancing going out, but we have the data to show that if you use the PPE the right way, you were not going to be infected by a COVID-positive individual. Your risk was when you were not at your job, that maybe your guards were down, you were doing things that you otherwise knew you didn't do at work, and you were exposed. And telemedicine is working. Most health systems were not on a platform, but today, most of you who probably want to go and see your primary care provider have done so via some form of a telehealth platform. And if you've gotten a COVID test, you probably didn't even set foot in the office of your primary care provider. You were directed elsewhere for some other type of a screening platform. We know that we have gaps. Obviously, state health departments were not built to handle a pandemic with source contact tracing. The Hispanic Latino example was great, because when we dealt with the state on this issue, They told us, oh yeah, we dealt with the same thing in Beaufort. A group of migrant workers in the field were all getting infected, so we pulled up on our state vehicles and we began source contact tracing. Well, that ended in a huge failure because of the fear of an undocumented worker. So there are some nuances that we've got to get better when it comes to public health outreach. And as I said, we told people that were being admitted with COVID those milestones when they were most at risk of succumbing to the disease, and we're very transparent about it. And having deliberate discussions with patients and their family care members. And I'll be the first to tell you that I think we all needed hope during the darkest parts of the first surge, but those ICU stories of someone coming off of a ventilator after a 4 or 5 week stay were never realities. Those were the needles in a haystack. The majority of those outcomes of long-term intubated ICU patients are not good. It's an incredibly high mortality rate that approaches over 70%. Integrated clinical learning. We were forcing our medical staff at a time in their training when they had technology at their fingertips at times to make the best decision you can with often was only 60% of available data, not knowing the testing status or when the testing status would come back, with treatments that sounded great, but in reality what we're left with now are therapies that have been around for decades, steroids, and an antiviral called remdesivir. But we're adapting. We continue to mask every day. We screen every person that comes into the facility, every physician, every visitor, and we limit visitation to certain times and only one visitor per patient. At these times, employee health has never been more valuable, I think, in any organization and in healthcare. For a system that has 3,000 employees, we had 2 staff members in employee health. Clearly not what you need during a pandemic. Now, where are things going? Well, this is where we are this week. So if you look at the DHEC data, you see the COVID-19 cases per day, and look at July. Those new cases that we see that have gone from November into December are dwarfing those number of cases. But the acuity piece that we'll get to in a minute is a little bit different. And when you look at these other, the graph to the right, Low Country, Midlands, and PD, that light blue bar, that's us. We're the lowest in the state of South Carolina in terms of how these new cases are accumulating. They're still in an upward direction, but compared to other regions of the state, not at the same level. This is what we look like in terms of positive test trends, going from May through the first surge into November and December by county. Dorchester County has got an impressive number of cases when you compare to Charleston and Berkeley County. That cannot be understated by those data points. What does it look like today in your state of South Carolina? And let's put this in perspective of maybe what would this look like on December the 9th of 2019? Well, the state has upwards of 90 acute care hospitals that can take care of its inhabitants with roughly 13,000 beds. So the important metric of all of this data, right now, 77% of the beds in the state are being utilized. But, newsflash, December the 9th of 2019, that would be the same number because we are in the middle of cold flu season that those beds are traditionally at a 77% occupancy rate. The difference that if we rolled the clock back during the July-August surge, we would have stopped operating electively, and those beds that would have been previously filled with a hip replacement or something else elective would have had a COVID patient in it. So where we're sitting right now today in the state of South Carolina is roughly 1,100 hospitalized COVID-19 patients that are sick enough to require hospital-level care. That's about 13% of all the available beds in the state of South Carolina. 23% of your ICU beds, but only 10% of those ICU patients are ventilated. So when it comes to state planning of need, those top numbers are important, but it's really those bottom 3 numbers of what are your COVID patients demanding of your healthcare systems. And this has been consistent relative throughout November and into December. These numbers are not varying widely in terms of the acuity of COVID. What does it look like regionally? Well, as of yesterday afternoon, I had 28 COVID positives in my health system. Our colleagues downtown had roughly very, very similar numbers. The VA health system in East Cooper have vastly different inpatient capacities and never really approached some of those highs that you saw, that we saw during the first surge, where having upwards of 90 COVID patients, or 146 as the Roper St. Francis system, and they opted to coalesce all of their COVID positives at one hospital at downtown Roper. So there were no COVID patients in their other 3 hospitals in the region. But when you have those levels, and you may have a 250 or a 300 bed hospital, and a third of your patients are COVID, that's all you're really doing is COVID-19 management. And that's where we were in the surge. But we've been in these numbers for the last couple of weeks. We'll gain 2, we'll send 3 home. So we like where we are, but we're not predicting that the acuity pieces of this second surge have completely played their hand yet. Now, where's the hope? The hope are in a couple of strategies. One is the vaccine, but I'm going to talk about the antibody first, which I hope you all have heard something about. Monoclonal antibodies, which when we started COVID-19, we were trying to use the concept of convalescent plasma, which was the plasma from the blood of recovered COVID-19 individuals and then transfusing it to hopefully curtail the hospitalization and drive improvement. That proved itself to not be as successful as we wanted, and in fact, we rarely do it anymore because the plasma with the antibodies of recovered COVID patients is highly variable and inconsistent. So Eli Lilly took that same plasma and synthetically created the same antibodies and made it in enormous numbers. And so now we have a product called bamlanivimab. And since Monday of last week, we have been bringing COVID-positive patients that are newly diagnosed within the first 10 days of their symptoms, that are well enough to not require supplemental oxygen or hospitalization into our hospital, and we're infusing them with this monoclonal antibody product over 1 hour. As of yesterday, we had treated 36 people, and roughly we're treating 5 to 7 a day as individuals find their way to us for this treatment. And a similar product called, it's the same one that President Trump actually received, also a monoclonal antibody. That one's being made available to us as well. So there's 2 of these monoclonal products. And the reason we do this is I would rather treat a patient who's COVID positive in my hospital that potentially avoids an admission at the other end of that same wing on the COVID floor. So that's the strategy, is to curtail the disease progression, to provide treatment. They're not cured. They leave the infusion center with the same instructions of isolation, symptom monitoring, and all the things that anybody else would receive, but we've given them a treatment option that until now, the past 10 months, nobody's been able to deliver, and we're the only ones in the region doing it in these numbers. Now the vaccine. About an hour and a half ago, the FDA Advisory Committee approved the Pfizer vaccine, so it is on its way to us. mRNA vaccines, of which the Pfizer and the Moderna are new. We do not have an existing vaccine that uses this technology, so these will be the first types of vaccines that are introduced in such a large-scale way. They don't give you COVID-19. They merely take the secret code of this virus, introduce it into your body so that you've got the destructive lock and key mechanism to eradicate the virus. We're due to receive the Pfizer product, which is stored at an incredibly low temperature. DHEC told us yesterday that we could expect to start receiving doses by Tuesday of next week. And Tier 1, or Phase 1, is all healthcare workers and all healthcare systems in the state of South Carolina and across the United States. And so this product will come to us with our doses, 5 doses per vial. That the kicker with the Pfizer product is I've got to get all of those doses into people within 5 days because of the sub-temperature requirements. And so it's going to be an enormous undertaking at our institution and others. And to give you all a kind of a glimpse of when your phase comes, it's going to be Phase 2. So Phase 1A, Phase 1B. Phase 1B is mainly those most at risk. Your congregate, overcrowded settings, nursing homes, etc. will be in Phase 1. The pace of the production of the vaccine and the different manufacturers making it leads me to believe that as soon as potentially February, we're going to be in phase 2, offering vaccinations. And our strategy is going to be incredibly simple when we start, is that we will be taking the vaccine to our healthcare workers where they are, what they're doing at the time, and treating them there. And then we'll have walk-in vaccine facilities on our campuses where individuals that may not be working over those 5 days will come in and get their dose. Individuals that may have practices outside of the hospital campuses will come in and get their doses, and we'll be doing it from sun up to sundown because of the 5-day requirement. So these are two very promising things that we have not had for 10 months that are not going to stop the COVID-19 phenomenon, because if we don't get to at least 65 or 70% of our nation taking the vaccine, we won't grow the herd immunity fast enough. So I keep telling people that masking, distancing, treatment therapies are going to be with us through most of 2021 and potentially into 2022 if we don't get this right, which is obviously going to impact your world of educating the region's children. Now, I put this slide up here with a little bit of caution. Our beloved Dr. Fauci, he's not going away either. He, in roughly 6 weeks, will be the President-elect's chief medical advisor, and he's largely going to be shaping our COVID-19 policy. He's done so through masking, distancing, testing, all of his other opinions. But he's really, over the last week and a half, he's had some interesting recommendations as it relates to your world involving resumption of schools. I've captured some of those in April, June. I mean, education, in-person instruction was largely off the table, and he had very directed statements of dynamics of the outbreak. Opposing having schools open in areas where the coronavirus is spreading in July. Continuing school closures in August. September, schools can only open back up once the virus is under control. More in September. Some schools may be able to open safely, but that places high COVID-19 transmission levels, may want to pause before they start sending kids back. So August, September, October, well, something started happening in December. December the 4th, very long, drawn-out statement. The default position should be to try as best as possible within reason to keep the children in school or to get them back to school. If you look at the data, which is true, the spread among children and from children is not really very big at all. Not like one would have suspected. So let's try to get the kids back. But let's try to mitigate the things that maintain and just push the kind of community spread that we're trying to avoid. I think he was kind of having a train of consciousness moment of what he was really trying to articulate. And then as recently as just Monday of this week, test positivity rate of children is lower than that of the communities they are in. Wow, that's definitive. The safer place for children is to be in the schools. So that's December the 7th. His role will change in 6 weeks, but I would imagine he will inform most political leaders and decision makers along those lines to some degree, barring a lot of change. So I want to pause leaving you with this, and I hope a lot of you saw this posted all over the low country, is that the regional healthcare systems were asked to kind of align and stay on message in terms of what are enduring public health policies, and they've been very low tech. Masking, distancing, hand hygiene, washing, adequate testing, all of the things that we've been discussing tonight. That's what's going to get us through the pandemic, in combination with contact tracing, with antibodies, with the vaccine, with access to health care and being able to treat those most impacted, because I'm still going to have patients with COVID-19 in my hospital this time next year. It will be happening. So this is going to be with us for a long time, and so I applaud all of your efforts that are struggling with this issue of what is the right call for children, what is the cadence, what does it look like, because if you all have discovered doing more research than me that nobody's got the right answer. But because it's an answer that has to have several questions in synchrony of testing, community-related acuity, treatment access, and how sick are those individuals who have COVID-19. So, thank you.
And for Dr. Biggs? Justin does, okay.
First and foremost, go Navy. Thank you for being here tonight. That was extremely beneficial to see it from the medical side, and especially here where it hits home is extremely beneficial. So good information. At the risk of sounding naive, can we go back to the basics? So just coronavirus in general. Coronavirus has been around. It's been around for a long time, correct? Just in general.
It has. The reason this one has the weird name it has is because there are so many subtypes. It actually has a SAR, 19N, COR to delineate it, but there's over 100 different subtypes of coronavirus.
Yep, so the different strains. So this particular strain, I guess, why is this one so concerning for us? Is it the lack of vaccine? Is it the way it presents itself? Is it the mortality rates?
Well, I think it's in its name. We've never seen it before. It's a novel, a new coronavirus that we don't have the ability, our bodies aren't able to quickly amount the antibodies we need. Now, that doesn't mean it's not happening, because of all those tests that are out there, what I was showing you was the burden, those most vulnerable that succumb to the symptoms that require hospitalization. As you can see from my numbers, for every person who has COVID, you're only going to have 1 out of 3 that gets admitted. So a lot of those individuals are recovering and are going to recover without any debilitation or long-term impairment, simply because they're doing what their immune system is designed to do. But the vexing part with this virus is that 3 days before a person has their first symptom, they are shedding viral load that they can infect multitudes around them. So it's unlike a lot of other viruses that we've seen, because it's already doing its damage before we even know it's there.
Looking at, so transmission, and we saw Dr. Fauci's statement there, but from your personal view, talking about the transmission, I guess maybe from, we're saying within the young population, maybe we're not transmitting as much, but as we look from young to old, let's just say, hey, from our students to our teacher population potentially, what does that look like? What are your thoughts there? Do you have concerns with that?
Clearly, anybody who has COVID-19 is a vector of the disease, which means they can infect anybody around them, someone of equivalent age or someone quite older than them. It doesn't really change what we've seen with children. I think we all held our breath in August, September as things were beginning to happen, because in the low country of South Carolina, we don't have enough beds to hospitalize the number of children that could have potentially ended up sick. As you saw in my data, at Trident Medical Center, we don't do OB or pediatrics. It's all done at Somerville Medical Center. The only individuals of a pediatric nature that have had COVID-19 have been newborns born to COVID-19 positive mothers. We've not seen a huge uptick in our EDs. We've not filled up our pediatric intensive care unit at Somerville to the degree that we're seeing that level of acuity. Does it mean it's not there? It's there, but it really is behaving more like a seasonal viral illness that is new to a child's immune system, that is a little bit different, hyper-tuned, more so than perhaps a 75-year-old. That I think there's a resiliency there that we're all very, very fortunate is occurring.
Yeah. And the last piece I would put out there, and I think this is part of the challenge, because one of the things you had talked about within the medical community, within the hospital system, not much of a spread, which is fantastic news. I think the hard part for us, and again, the challenge when we look at our school environments, our educational environments, we've got educators, we've got teachers who are not medical professionals, we've got kids who obviously, like me right now, want to take their mask off, and and all that sort of stuff. And so I think that's the challenge. I would love to say that our schools are not going to have the high rates of transmission that the medical side hasn't seen, obviously. But again, I don't know that we have those medical professionals. Again, just a challenge I think we need to be careful of. Thank you again.
Listening to what we talked about earlier with the hybrid and whatever, do you think it's safe for our kids to stay on the hybrid system?
That's not really my recommendation point. I think that's a decision that's obviously made by the board leadership in concert with their employees and the parents. Obviously, there are opt-out strategies. When this was coming about, of what the schooling philosophy would be, a lot of news organizations were reaching out to healthcare. What are our thoughts? What are our thoughts? It was really simple as, okay, does everybody's plan have a built-in exit strategy or escape valve, right? What is the threshold? And from what I've heard is that it's all very well thought out, and the acuity in the region, the acuity, because clearly what we saw when we had so many COVID patients in our hospital, I didn't have enough nurses to take care of COVID patients, so I had to take nurses that usually did surgery or cardiac care or catheter or other procedures and become COVID nurses. And so in a situation like schooling, it's not necessarily apples to apples, but you're going to have staff portioning challenges by either individuals who choose to opt out, and in the nursing field in particular, we have seen many of our nurses across all the health systems make life-changing decisions that this is not the profession that they want to be in. And right now in the Low Country, there are over 800 job postings for registered nurses. And so most of all of our health systems, nurse staffing right now are paid travelers. And so you could very well find yourself in a similar dilemma of if you have opt-out strategies and people are following their conscience, as they have every right to do. But I would be hesitant to give you a recommendation of what is the right model. But I think if you've got consent and you've got an exit strategy for when it gets too hot, like what we've said for everything, okay, you're going to know when it's time to cool the things off, and you're going to suspend. I think that's the reasonable ask that your community is looking for.
But can I add to that? When you say it gets too hot, are you looking at within our schools or within our community? Should we be concentrating on what's happening in our schools, or should we be concentrating on what's happening in the community? Both.
Because in Synchrony right now, we're sitting on increased positivity. We're seeing some increases in those being admitted. You're seeing the same thing. You know, we're heading for something. I really anticipated post-Thanksgiving it would be at about the 7-10 day mark, because that's generally the way it should happen. This is a little different. It's tending to smolder a little more. I think there's a fair amount of COVID fatigue where people just need to do the social things that they need to do. And they're, through no fault of their own, they're getting exposed. But the typical exposure in my world is a healthcare worker has a social gathering with a close connected family network that the next day that person calls them and says, I tested positive. And then it comes into my world. That's the typical exposure we see, and probably what you're seeing. So those are the challenges, and I think you can't necessarily make your decisions based on what you're seeing in your school. You need to see what the rates look like in your county, in your region, and how many hospital beds do you have? Are your hospitals heating up? Because that's going to tell you what the right decision is.
If we were to stay where we are now at the hybrid method, would that concern you for what could happen in the hospitals? Would it worry you, I guess?
Well, we've not seen the childhood piece of this, fortunately, thankfully. We've seen the adult piece of this, for sure.
May I just, because you're an expert and you've been so transparent, and we hear rumors, and you can just tell me it's a rumor or whatever, but if someone were to die of a heart attack, but they also saw that they had COVID, what does their death record say?
It can vary by who pronounced the death and the documentation. I think your real question is, are there actually more COVID mortalities out there?
Right.
There are. There are what I would call COVID potentiated mortalities, because what we saw in July and August in concert with local EMS from the 3 counties is there were very few EMS runs. People were afraid to access healthcare, which means they had heart attacks, strokes, disease progression. So when they came back into the hospitals in late August, September, they were incredibly sick. Sicker at times than we could take care of. And so were those COVID mediated? Clearly they were indirectly. But yes, an individual who comes today or comes to the ER having had a stroke, they're going to be tested for COVID-19. We're going to have that in the background, but the way health registry data is geared right now, COVID-19 is not always going to be the first thing on that death certificate.
Thank you. Is there any more questions?
Hey, Doctor, just a quick question. One of your slides referred to what Dr. Fauci said as far as children being safer in schools. I think, to echo Mr. Farnsworth a little bit, it didn't reference that adults were safer when children were in schools. And I think, what would be your plan if you were us to put the word out? How do you make the adults, or how do you get the adults to understand that there is safety and security in their returning to school? Because obviously students can't return on their own. There needs to be teachers, custodians, food service, bus transportation, administration. So you can't really have one without the other. So it kind of, it's a little odd.
Yeah, and I think your data obviously tonight reflect that your leaders of most of your schools and the teachers of most of your schools are really not in favor of a large-scale return of the students into a full model as I interpreted it. So that's hard. I don't have the same problem because every day when my healthcare workforce shows up, they've signed up for that task, which means they might have 1 COVID, 2 COVID, 3 COVIDs, but I've given them proper PPE, a face shield, a gown. I've given them precautions to where they can't be within 6 feet for greater than 15 minutes, and for doing an aerosolizing procedure, we have other precautions. So I've given them a script. I can't give you a script for an 8-year-old that may want to put their hands in their mouth and touch their classmate's earlobe. You know, I don't have a script for that. And I don't know if you all do either. I don't. So it is a bit unpredictable, but I can tell you what we've done with our health system by being overly transparent is we've told people there in the dark days where we've got 20 COVID tests the rest of this week. We hope the vendor's going to bring us more. This was in July and August. I think the same would be asked of all of you, and I gleaned that you're very transparent with who's being impacted. If you're going to be introducing testing into your schools, that's a tremendous force multiplier as well. So testing, conversation, exit strategies, everyone's being heard. You can't really ask for more than that. I think you're going to have to realize that you're going to make it a decision at some point where 1/3 will be happy, but 2/3 will probably not. That's the nature of public policy and what you've been asked to do.
Apologies, I thought of something while we're talking about the testing piece there, because we are actually already starting to see some communications come in regarding testing and schools and all that sort of stuff, because I know that's being pushed down and talked about from the state level. Can you talk about so the benefits, are we talking about kind of the rapid testing? Like, what's the benefit? So let's say the state mandates us that we have to test every single student. Is it to basically pinpoint before there's an issue?
Well, I think if you look at entities in either the entertainment, sports sector, they've tested to create bubbles or notional safety zones where individuals in that particular bubble are really not interfacing with those outside of the bubble. That's where you've seen that very regimented daily or every other day testing. And, it's not worked. I mean, how many athletic venues have been postponed because of one positive test? I mean, that doesn't work. But having the ability to test sure does. I got to tell you, it was not fun being a chief medical officer in February and March, when I couldn't test anybody. And I had to, and most of my staff felt more like veterinarians than doctors, because they were guessing what the right treatment would be, hopefully. So testing addresses all of that. That identifies positivity, source contact tracing, exposure degree much faster than it otherwise would be when you go. And as I said, most of you today will not walk into your primary care doctor's office if you think you have COVID. Those are going to direct you somewhere else to be tested. But if you've got that ability in the school systems, you can very quickly identify clusters or hot spots, more so than that information would come to you secondarily.
Yeah, and that's where I'm trying to get, because the question is really, what I'm seeing, the question is really, should schools be responsible for that mass type testing? versus a parent saying, hey, I don't want the school testing my kid.
I got to tell you, I've had the posture of anything that is offered to me in the COVID world, I say yes, because it's more than what I did not have yesterday. I'm going to be given 5,000 doses of vaccine to give here in the next week. I'm going to probably be given way more than that for phase 2. And we will be rolling up sleeves in our campuses to anybody and everybody who wants the vaccine. So I think COVID-19 is a time to say yes to everything.
And I didn't want you to think that I'm saying either way. I'm just saying the question we're seeing is, hey, why are schools forcing my
Meaning,
kid
are
to
you
get tested?
responsible secondarily? You're really not. You're accelerating care when you provide testing, because I can guarantee you there are certain employers that would love to have the ability to have on-site testing.
What would the liability be on our nurses to do that, or would there be?
It's a very simple collection process. It's somewhat irritating. I've had it done myself a couple of times. That's what it entails, of being able to get the result and notify and isolate. I would think most of your staff would welcome the opportunity to be in that space, particularly when a child that may come to you where family dynamics may not be what they optimally could be, and access to health care for that at-risk child may not be what it should be. And so if you can address that need at school, then that's a good thing.
You mentioned earlier, I think this is what I heard, that actually they could be spreading the virus 3 days before they are symptomatic.
Yes.
Saying that, the exposure's there, so if we begin the testing in the schools, can you, at that point, if we test them as they come in or whatever, even if they're not symptomatic, would we be able to detect that in them during that test at that time, or do they have to be showing some type of a symptom in order?
No. I mean, we've had our testing experiences that we have had positives come back in individuals that have been asymptomatic. The unique nature of this novel coronavirus, the manufacturers of these products have lowered the sensitivity threshold so low. I've got patients that have been in my hospital for 4 weeks with COVID that you would think, in theory, they've cleared it, will still test positive. Because initially, skilled nursing facilities or nursing homes required a negative test for post-hospital placement. I could never get to that point because they never cleared it in sufficiently low enough. Now, they weren't sick. These were recovered, well people, but still were testing positive. So here again, we have to go back to what is the positive test telling me? Where am I in that course? If you have a child that clearly has COVID-like symptoms and has a positive test, absolutely you know what that means. Mm-hmm. If you had a strategy where you were trying to create a bubble, which you really can't in the school system, this is not a football team or a sports team, you're going to be calling it as you see it and doing the best you can with those results.
Right. And I think we had one of our administrators, I think, had a question earlier that they had wanting to ask or whatever, but, and I think, she's still here, I think. Yep, she's here. Just if Ms. Fenari, if I don't say this correctly.
Did I have a question?
Yeah, you were saying something about it, but if there is if someone, of the people that you have in the hospitals that are testing positive or in the hospital for COVID and do not get it to the extreme of passing away or whatever, what are some of the other side effects or other symptoms that occur or that you're seeing that are occurring from that, or long-term effects or whatever that are coming from that?
I mean, long-term effects will probably take us another 12 to 18 months, but what we're seeing in the short term is individuals have a very long pathway for return of taste and smell. With any viral illness, it takes a very long time for those particular nerves to return functionally. And since this is mainly a pulmonary disease, like any pneumonia, an individual can be incredibly short of breath for many, many months post-COVID pneumonia. And so those are the most common ones. Now, are there other potential autoimmune or rheumatologic conditions? Certainly, but they're a bit all over the map right now to where that pattern hasn't made a very clear outline as to what we can predict long-term.
Well, Dr.
I have one.
Biggs,
Sorry, could I ask one more question? You mentioned that you think a surge is possibly coming. Do you have a prediction for when that could be?
Well, we look at our positive testing run rates. Since patients who come to us are symptomatic in some degree, if we start moving off of that, we were about 13.5%. If next week I'm moving close to what I was in July, if I'm getting to 20%, then I'm going to be admitting those patients, which is they're going to be filling up beds, and that's my disease burden. So we've traditionally looked at our positive run rate through our acute care, emergency rooms, and treatment facilities as a predictor of what's likely to come. And we've been in that 11.5, 13.5 for October, November, December, and we're only at the 10th day of December. So, and it's, a month ago, I had 12 COVID positive patients in my health system. So there are a lot of models out there, but most of our models look at our testing run rates as a predictor for hospitalization acuity.
Okay, it's 8 o'clock. Dr. Biggs, you have been a wealth of information. You have been so kind to answer the 40 questions. But everybody out there that's listening needed to hear the same thing. I feel like we just had a medical class 101 on COVID virus, and we cannot thank you enough. So thank you. And at this time, we will adjourn. Thank you all for being here.